Notice you're someone you're not. If you look in the mirror and don't like what you see, you can find out firsthand what it's like to be me. So gather round, piggies, and kiss this goodbye. I'd encourage your smiles. I expect you won't cry. Another contusion, my funeral jag. Here's my resignation, I'll serve it in drag. You've got front row seats to the penitence bar. When I grow up, I want to be Don't forget that you
Good morning, everybody. Welcome to COTAC. Flip your cameras on for me. Hello, hello. Okay, so the plan for today is to do attendance, and then we'll go into the cardiovascular assessment and coronary disorders lecture. Okay. Next week, worksheet 4 is due. Let's talk just for a moment about the worksheets. I'm giving you credit if the questions follow the categories like patient education, nursing considerations, whatever, and if they are pertinent to the stuff we're talking about, so like respiratory diseases or cardiovascular diseases, right? I am not correcting your worksheets. That meaning if you put a question there and gave me an answer and it was not right, I'm not pointing that out. Okay, so I'm not correcting your questions. So ensure that if you're going to use these as a study guide, that you've got good questions. Okay. Okay. I've also posted a couple of announcements last week and this week on how to do references. I think I've had like one student get their reference page 100% correct. So you're all missing just a little bit, and I'm putting edits on all the documents to help you see and learn and be able to change your reference page before you get to the final document. Okay. So definitely look in. Yeah.
Sorry, I didn't mean to interrupt you. I just
no
wanted
worries.
to know
Go ahead.
if we made the corrections. I know you're giving us full points even still with us having mistakes on it. If we turned it into you again, can you let us know if it's right before we submit our paper? Okay.
Absolutely. Yeah. I'll correct it for sure. The references were due today though, so it'll be close to you. So if you want, you can email them to me. If you want me to check them again, just email them to me. Yeah, that's a good question, Dominique. Thank you. Any other questions about the reference pages or the worksheets? Okay, your next section is your disease section, but that's not due till week 5. But that section should tell me everything I could possibly need to know about your disease and the background, how you test for it, history, comorbidities, assess, like anything that you want to talk about in there. I want a thorough explanation of your disease process. Okay. Okay. The weekly tutoring time is actually tonight at 8 p.m. I'd love to have you guys there. I purposely put it a little bit later for those of you that, you know, it's 8 o'clock is a little easier to get to things. So if you'd like to come tonight, we're going to talk about what we'll talk about today. We'll answer any questions regarding respiratory if you guys haven't taken the exam yet. And then we'll talk about APA formatting and how to write APA. Okay. And then your exam, your respiratory exam is open. So if you haven't taken it, take it before tomorrow at 23:59. Okay. Okay, anybody have any questions about anything before we do roll? Fantastic. Okay, I'm going to assume that you know what you're doing then. Okay, Abby.
Here.
Thank you. Kirsten. Kirsten Anderson. I think I got an email from her. I'll check. Well, I'll look into that. Blair.
I'm here.
Thank you. Haley Bettinson. Thank you. Bethany.
Here.
Thank you. Carly.
Here.
Thank you. Amelia.
Here.
Thank you. Camilla.
Here.
Thank you. Shane.
Here.
Thank you. Liz.
Here.
Thank you. Riley Elton.
Here.
Thank you. Myra.
Here.
Thank you. Corbin.
Here.
Thank you. Indy.
Here.
Thank you. Olivia.
Here.
Thank you. Dominique, we talked to. Harmeen.
Here.
Thank you. Jasleen.
Here.
Thank you. Samson.
Here.
Thank you. Devin.
I'm here.
Thank you. Erica. Erica, wave your hand. Okay, there you go. I can't hear you, but I can see you were unmuting, so thank you. Macy, Macy,
Here.
thank you. Bailey Loftus,
Here.
thank you. Carla,
Here.
thank you. Brianne,
Here.
thank you. Tracy,
Here.
thank you. Kevin,
I'm here.
thank you, sir. Jensen,
Here.
thank you. Michelle,
I'm here.
thank you. Taylor,
Here.
thank you. Whitney,
Here.
thank you. Stephanie,
Here.
thank you. Riley Robinson,
Here.
thank you. Jill,
Here.
thank you. Christy,
I'm here.
thank you. Eric,
Here.
thank you. Anna,
Here.
thank you. Caitlin. Do you have Caitlin Watts here today?
Yes, I'm here.
Thank you. Sherry,
Here.
thank you. Okay, does anybody know where Kirsten is? I don't remember.
Professor.
Oh, there she is. I'm like, I swear she emailed me, but I don't remember what she emailed me about. I don't think it was she was going to be absent. Okay. Awesome. We got everybody then. Okay. Are we ready to go? Okay, let's do it. So cardiovascular assessment and coronary disorders. So we're going to talk about assessing the cardiovascular system first. We'll do a little anatomy review because it has been at least a year since you guys have had anatomy. So we want to make sure we're up to snuff on that. We'll talk about cardiovascular health history, cardiovascular physical assessment, and then diagnostics for cardiovascular system. So our anatomy review. Everybody look at me. Look at me. Everybody look at me. Pretend I was grabbing your cheeks and making you look at me like you're my child. You must be able to trace the drop of blood through the heart. Okay. Now, I know you've been told that before, but I know there are tons of you out there who don't know it yet or don't have it memorized. I want you to be able to do it with your eyes closed, standing on one foot, frontwards and backwards. Well, the frontwards and backwards part, yes, but you don't have to stand on one foot. Okay. But if you can trace a drop of blood through the heart, it's going to make it exponentially easier for you to think, well, if I have a mitral valve disorder, that means not enough blood is leaving the left atrium, which means my lungs are getting full, right? It helps you think through disease processes, okay? And it's going to help you a ton on this test, this first cardiac test, second cardiac test, and the final, okay? So absolutely do it. So let's do it. Anybody want to volunteer? Can anybody start with the superior vena cava and go through the whole thing?
Deoxygenated blood, right atrium, tricuspid valve, right ventricle, pulmonary artery,
Valve first.
pulmonary valve, then pulmonary artery to the lungs,
Mhm.
and then pulmonary vein to the left atrium through the mitral valve, through the left ventricle, then the aortic valve.
And then the aorta is all. So that's pretty much it.
Okay.
Well done, Eric. Thank you, sir. That was amazing. So you all should be able to do that. Did you see how Eric was also looking up and over? He wasn't looking at the slide while he did that. He did that from memory. So I expect you all to be doing that as well. Okay. Thank you so much, Eric. Now, what I want you to know are obviously the vessels, the chambers, the valves. There's 4 chambers, 4 valves. I want you to know that there are coronary arteries. I do not expect you to be able to label all the coronary arteries. It's really not necessary. Just know that there are coronary arteries and that the blood comes from the heart and feeds the heart muscle. Okay. Some terminology we want to review: cardiac output. Cardiac output is how efficient, let's go with that, how efficient the heart is squeezing the blood out. So with every oomph, we should be getting a good amount of cardiac output. When our hearts are sick, that oomph gets a little weaker, a little less effective. Okay, so cardiac output is the how effective your heart is in pushing blood out every time it pumps. Okay, preload is the pressure your heart has to overcome to contract. Afterload is the pressure that's left over after it relaxes. They're very similar. Really, all I need you to know is afterload has to do with peripheral vascular resistance. Pulmonary vascular resistance and systemic vascular resistance. So pulmonary vascular resistance is how much pressure is in the lungs. So if I have a ton of pressure in the lungs, I don't care how hard that heart is beating, it's not all going to get shoved into the lung, right? So it increases pressure in your pulmonary artery, which will therefore increase your afterload. Requires more effort to get that blood out when there's high pressure, okay? Same with systemic vascular resistance, but that goes for the rest of your body. If you have high blood pressure all over the rest of your body, it is affecting your afterload. It's increasing your afterload. Okay. Now, gender considerations. Usually there's not a ton of difference between men and women, but there's a couple things to note: that women have smaller hearts and arteries in general. Now, obviously, if we took a very petite man and a very large woman, her heart might be bigger, but in general, men have bigger hearts. Okay. But surprisingly, women actually develop coronary artery diseases 10 years later than men do. So even though our arteries are tinier, they get clogged 10 years down the road. Now, estrogen helps with that. Estrogen helps keep our atherosclerosis a little bit lower. But then I'm sure there's a ton of other things, the differences between the sexes, that would contribute to that statistic. Okay. Questions about this?
Can you explain one more time what pulmonary vascular resistance is?
Yes, I absolutely can. So pulmonary vascular resistance is the amount of pressure in your lungs. So let's say you have your lungs here, but there's a clot. And so the blood is having to push really, really hard, and all this pressure is building up, and there's no pressure over here. So the heart is pumping even harder to try and dislodge that clot. So the resistance is how easily is blood going through the lungs. Did that help, Liz? Okay. Any other questions?
Yeah, sorry. Can you tell me what SVR is one more time?
Systemic vascular resistance. So that's how high is the blood pressure in your arms and legs. If the arm and leg vessels are narrower, the pressure has to be higher to get through. I always think of blood pressure as a garden hose. You know, if you're just leaving the garden hose, it's turned on and water will come out. But if you put your thumb over the top, you're narrowing the vessel so the pressure goes up. You know, when you put your thumb over the top and now you can squirt 10 feet instead of 3 feet, right? So that vascular resistance is how big are your arteries and veins in the rest of your body. That's what systemic vascular resistance is. Does that help, Brianne? Good. Okay. Anybody else got any questions? Okay. Let's do our first polling question. Remember, if you're not going to talk to me or text me on the chat, you need to answer all of these questions to get full participation points. Okay. So there you go. Give that one a try. We know Eric can do it. Okay, let's do another 10 seconds. Okay, so the answer we're looking for here is the second one. Superior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary, oh, we missed pulmonic valve in there. Oh no, it says it, pulmonary valve, pulmonary arteries, lungs, pulmonary veins, left atrium, mitral valve, left ventricle, aortic valve, aorta. Oh, there's not aortic valve. No, there is. I keep looking at the wrong one. Okay, so let's talk about why the first one is wrong. Superior vena cava, yeah, but not straight to tricuspid. We got to go through the right atrium. So that's why the first one is wrong. The third one, superior vena cava is right, right atrium is right, tricuspid valve is right, then it goes right ventricle. So that's where the third one goes wrong. Not from the right atrium to the left atrium. That's a bad thing. That would be like a PFO. Okay. And then the last one, superior vena cava is right, right atrium's right, but then we go to the tricuspid valve, not the mitral valve. I was taught try before you buy, because the mitral valve used to be called the bicuspid valve. And for some reason, every 10 years or so, they like to change up anatomy terms. So now it's called the mitral. So now I'm thinking, try before you buy my present, right? So tricuspid on the left, mitral on the right. That's how I remember that, if that helps anybody. Okay, so now let's talk toilet paper. What? Okay, tell me, what is it?
It's the name of the valves. Toilet paper, my ass.
Toilet paper, my ass. Yes, you're right. It is. I never heard that before. Okay, there you go. Jill's got another way for you to remember it. That's much more catchy than mine is. I like it. I like it. Okay. So now let's talk about electricity of the heart. Electricity of the heart goes a different pathway, right? Blood goes inside the heart. Electricity goes in the heart muscle, in the myocardium, not in the endocardium where the blood is. So cardiac electrophysiology is designed to maximize cardiac output, okay? The SA node contracts the atria. The AV node gets the electricity, but it holds it for a second so the atria can relax. And then the ventricles contract as the AV node sends the electricity down the rest of the pathway. So your heart, when it's healthy, goes atria, relax, ventricle, relax, atria, relax, ventricle, relax. Like this, okay? Maximizing cardiac output. So the SA node starts in the right atrium, but it actually innervates both atria. It doesn't just shock the right atrium, it shocks the left atrium as well, okay? So we go SA node, goes down to AV node. AV node, like I said, it holds it for a second. It pauses so the SA node can relax, so the atria can relax. And then the AV node will shoot the electricity down this really fast highway called the bundle of His, okay? The bundle of His bifurcates into the right and left bundle branches. And then those branches bifurcate all over the place into Purkinje fibers. And the Purkinje fibers innervate the myocardium. So the pathway of electricity goes SA node, AV node, pause, bundle of His, right and left bundle branches, Purkinje fibers, myocardium. Questions on that? Okay, this, hopefully all of this so far should be like a review, right? Okay, so now let's talk about what parts of our physical assessment, what parts of our health history we need to talk about when we're worried about cardiovascular health. So tell me some common symptoms where you would be like, oh my gosh, you've got a heart problem. What are some common symptoms for heart health issues?
Shortness of breath.
Shortness of breath, absolutely. What else?
Edema.
Edema, very good. Chest pain, good.
Chest pain at rest.
Chest pain at rest is a huge one. Okay. Jaw pain, I see. Thank you. Okay. What else? We got a lot of them. But, oh, what, Dominique? Sorry?
Fatigue.
Fatigue, absolutely. Nausea, yes. Your heart affects pretty much every part of your body because it's pumping blood pretty much to every part of your body. So even weird things like my fingers are clubbed, that could be a heart thing, right? Things like edema, that could be heart failure, right? So good job, guys, good job. So now, what kind of things would we want to talk to them about regarding their past health, family, and social history if we're concerned about their heart? What do you want to know? What do you want to ask your patient?
Have you ever had high blood pressure or diabetes?
Perfect. Those two are huge cardiovascular issues, right? Good, Liz. What else, guys? Oh, smoker. Absolutely. Remember, smoking doesn't just hurt your lungs. It gets into your blood and hurts and irritates your stomach lining and everything. It's really bad, right? Okay, what else?
BMI.
BMI. You're exactly right, Eric. Now, obviously, you're not going to say, excuse me, what's your BMI? If you ask a woman that, she'll slap you. So don't do that, right? But you can kind of see, are you a normal-ish weight, or are you overweight, or are you underweight? Because being over and underweight are both cardiovascular risk factors, right? Diet, that's great, perfect. Familial heart issues, absolutely. There's so many genetic things that have to do with cardiovasculature. Exercise, stress, absolutely. All of these things can hurt your heart and your cardiovascular system. Good job, guys. Good job. Lifestyle, yeah. Okay, what medications do you want to know about when we're assessing for heart health? What medications are they taking that we want to know about?
ACEs.
ACEs, absolutely.
Diuretics.
Diuretics, for sure. This is kind of a trick question. I want to know literally everything they're on, right? Because beta blockers, ACEs, diuretics, those are important. Those will tell me, oh, they already know they have heart issues or blood pressure issues. But if they tell me they're on St. John's wort, this is an over-the-counter herb that makes you hyper anticoagulated. Is that the word? What's the word for hyper anticoagulated? Is there a word? It makes you real bleedy. Okay. So obviously that can affect your heart health. I want to know everything they're taking. Okay. Nutrition, we already talked about. Now, how are you going to assess a patient's nutrition? How would you go about doing that? Anybody got any ideas?
Food journal.
Food journal. Who said that? It highlighted. Who was that? Dominique, perfect. A food journal is really good. 24-hour recall is sometimes good. But you guys, can you remember what you ate yesterday for breakfast? Unless it's the same thing you eat every day, right? It's like, oh, what did I eat? Was it eggs or yogurt yesterday, right? So 24-hour recall is helpful, but it's less reliable than a food journal. If they have a food journal, that's a great idea. Okay. Okay, how about elimination? What does asking about their poop have to do with their heart health?
Well, if their kidneys aren't working and they're on dialysis, you want to know that.
Absolutely, right? If your kidneys are shot, your heart is doing extra work that the kidneys couldn't, right? So we definitely want to know about that. How about bowels? That's good for kidneys. What about bowels? What does that have to do with anything?
The first thing that comes to mind for me is if they're constipated and they have they're pushing, and that's what.
Right. You guys have heard of vasovagal syncope, right? It's when you poop so hard you pass out. That's a heart thing. Your cardiac output couldn't overcome your constipation, the pressure in your chest, right? So that's very good. Very good, guys. Now, how about, well, we talked about activity and exercise. Do you guys know that the ADA, no, not the AHA, I apologize, the AHA, the American Heart Association, advises that every adult exercise 30 minutes 3 times a week of vigorous exercise. Now, vigorous exercise just means you're sweating. So what's vigorous for me would be like a brisk walk. But what's vigorous for other people, you might have to run 3 miles before you start sweating, right? It depends on the person. So you're supposed to do 30 minutes 3 times a week of vigorous exercise. And so you have to kind of wheedle it out of your patient. Do you exercise? Sometimes. Oh, well, how many times a week? How long does it go? What are you doing? Kind of thing. Okay. We also want to assess the patient's self-perception and self-concept. What in the heck does that have to do with cardiac health? Any ideas? Why do I care if my patient loves themselves?
If they have like a distorted body image, then they might not be willing to go and work out.
Absolutely. That's a huge thing, right? People who are bigger don't want to feel judged, even if they're not being judged, will feel like it, right? At the gym. Okay. What about if your patient doesn't think their life is even worth anything, right?
They're not more, because they won't be more compliant with medications and willing to take care of themselves.
Perfect. Perfect. Also, did you know that your feelings can actually affect your heart? You guys, your feelings and your brain are incredibly strong in taking care of your heart health. Okay. So when you have terrible, sad, depressing ideas and feelings, that can actually cause your heart health to decrease. Okay. So those do have a correlation there between mental health and physical health. Mental health can absolutely affect your physical health. And I'm sure you guys have all felt that before, right? You just don't feel good when you're really, really sad or really, really depressed one day, right? Okay, roles in relationships. So in this one, I'm talking about the fact that you're nursing students, the fact that you're parents, the fact that you're spouses, the fact that you're children, whatever relationship you have, the fact that you're friends, right? How do those affect your heart health? Any ideas? Is having a family good or bad for your heart health?
It
For
depends
some,
on the
it could
whole
be
diet.
good, or
It absolutely, you guys are both right. For some, it could be good. For some, it could be bad. I'm going to tell you, every day it goes good, bad, good, bad, good, bad, right? I love it when my daughter hugs me and I feel so good. That's good for my heart health. But then she won't listen to when I tell her to do something, and that's bad for my heart health. And then she does something really cute, and that's good for my heart health, right? So every role in relationship we have, up and down, up and down, up and down, right? Now, those toxic relationships everybody's been a part of, right? Those people that are just negative and it's just really difficult to be around. Those ones, being around that constantly is not good for your heart health. Okay. How about sex and reproduction? What does sex and reproduction have to do with heart health?
it decreases stress.
Yeah, sex can decrease stress. Now, as Carla knows, because I just heard her little babies talking, reproduction can also increase, right? Having kids can increase your risk of heart issues. Okay. They can, I feel like sometimes my daughter is just going to give me a heart attack because she has no concern for the world around her. It's insane. It's stressful, right? Let's see. Sex is a good workout, right? Even if all you're doing is literally lying there, you're not doing anything. Your partner's doing everything. The fact that you're getting physically stimulated actually increases your heart rate, which is a form of exercise, right? So even if you're not doing anything tricky at all, right, it's still exercise. Reproduction. How about ladies when you're pregnant? What does that do for your heart health?
Well, does it have to pump harder now?
Yeah, because when you're pregnant, you actually have, I think it's like 33% more blood in your body. You get whatever the percentage is, you have more blood. So your heart has to work harder, essentially, because you're feeding two bodies now, right? Okay, let's see. Coping and stress tolerance. Okay. How does your ability to cope affect your heart health?
Well, if you're stressed out all the time, you're constantly releasing those hormones,
Which are not good for your heart in the long run, right? Short little bursts of hormones, fine. Actually, they're good. But long stretches of epinephrine and dopamine or whatever's happening can really affect your heart health, right? So the whole point of these last few was to help you realize that your emotions and your way of thinking physically affect your body. Okay. Okay. Any questions related to cardiac health history?
On the flip side of reproduction, when you have that much excess blood volume and your body can't handle it, then what?
Then you get things like heart problems when you're pregnant. You get murmurs. Lots of women have murmurs already, and it makes the murmurs worse when you have a lot of blood volume. Worst case scenario, because that's my skill, right? You develop acute pulmonary edema and drown in your body fluids.
Oh, fun.
Yeah, no. Being pregnant is not for the faint of heart, literally and figuratively, right? That's why they always want you to be healthy before you get pregnant, because being pregnant is a big health risk. Big health risk. Good question, Jill. Thank you. Anybody else got any questions? Okay, let's talk about chest pain. You have all been conditioned to think chest pain, heart attack, right? That's good. I want you to assume it's a heart attack until proven otherwise. Because on the scale of things chest pain could be, over here is like heartburn. And over here is like abdominal aortic dissection, like the worst thing that you'll die of in minutes. Okay. Right in the middle is heart attack. So if you assume it's a heart attack, it's easier to divert this way if it's something like heartburn, or divert this way if it's something really tragic. If you're all the way over here assuming it's heartburn, but it really is abdominal aortic aneurysm, that's a huge span to cover. So we're always assuming heart attack because, one, it's pretty dang common in America, and two, it's kind of the middle of the road for terribleness as to what chest pain could be. Okay. So if you see chest pain like this right on the heart, and it kind of comes up to the collarbone and down the pec muscle, it could be hiatal hernia or GERD pain, could be a muscle spasm, or it could be a heart attack. Okay, or it could be a myocardial infarction. Myocardial infarction and heart attack are the same term. Okay, if you get pain, oh, go ahead. Did someone have something to say? Okay, I must have heard something. Okay, if you have pain here in like your upper gastric area and your lower lobes, could be pneumonia. That's what PNA stands for, is pneumonia. Could be a pulmonary embolism, or it could be a heart attack, right? If you've got pain all through your whole chest, like in this big square area here, could be anxiety. Anybody ever felt anxiety so bad it hurts your chest? That's your mental health affecting your physical health, right? So it could be anxiety, it could be a panic attack, could be costochondritis. That's when the muscles in between your ribs are inflamed. Or it could be a heart attack, okay? If you've got it here and it goes all on your heart, radiates down both arms, goes around both sides of your back, up in your neck, it could be pericarditis, or it could be a heart attack, okay? Now, these symptoms that we usually associate with heart attack, left neck, left chest, left arm, jaw, these areas, that is only the normal showing on usually white men that are not elderly and not young. So everybody else besides those white men, like women, we do not present with heart attacks in this way usually. Like maybe we'll have a little bit of this, but maybe we'll have more of these pains. So do you see why it's important to assume every chest pain is a heart attack until proven otherwise? Because every chest pain, no matter where it is, could be a heart attack. Because not everyone, unless you're a middle-aged white person, white man, is going to present this way every time. Okay. Make sense?
Professor Sollis, I
Yeah,
thought
go ahead.
that in women it showed up more for arm pain if you're having an MI.
It does. It usually does. Yeah. And there's still, oh my gosh, it's getting better, but there's still kind of, with the older generation of doctors, they see women having heart attacks and they think, well, you're just being hysterical because you're a woman. That still happens. And women have been literally sent home during heart attack, mid-heart attack, because the doctors are like, you're just a hysterical woman. It's getting better. Younger doctors don't really do that. But the older doctors of the older generation, where they assume men are better than women, assume men can control their emotions better than women, right? Which is not right at all. But yeah, it absolutely can. It presents differently. So it makes it harder to diagnose, which is why we just automatically assume heart attack until proven otherwise. Good question, Dominique. Any other questions? Okay, let's talk about the physical assessment. We're going to talk about what parts of your physical assessment are related to cardiovasculature. Okay. Obviously, the first one's your general appearance. You're going to see their level of consciousness, right? Are they talking? Are they sleeping? Are they crazy, right? That's going to tell us something about the heart health because I can see that you're looking at me and talking to me and moving. I'm going to assume you've got adequate cardiac output. Now, if my patient were to suddenly pass out, I could think, maybe that's a heart issue. Could be a lung issue, could be a heart issue, could be a brain issue, but obviously it gives you a little bit of input, right? So level of consciousness can help us a little bit with heart health, okay? Mental status. If your heart is broken and not working for some reason, you're not going to have alert and oriented times 4. Right? Now, obviously, we can have other things that affect our mental status, but if our heart is not healthy enough, mental status goes out the window. Okay. And then BMI, which we talked about earlier. High or low BMIs can affect heart health. Okay. Okay, another great physical assessment tool is to do a neurovascular assessment. Neurovascular assessment is essentially looking for, hey, is there a problem that could be blood circulation or nerve issues? Okay, this is where we do the neurovascular assessment of the skin and extremities. There are 6 P's. Okay, I want you to memorize these 6 P's. Now, I'm not going to ask you what are the 6 P's on a test, but understanding these 6 P's means if you see a problem, there's either a neuro issue or a blood vasculature issue. Okay, so here are the 6 P's. Pain. Obviously, let's pretend I have a tourniquet on my arm. Okay, you leave it on long enough, my hand is going to start to hurt, right? You guys have all like slept on something wrong and then you wake up and it's kind of painful, right? So pain is your first one. Pallor. Pallor means getting paler. So in a white person, pallor goes whiter. In a black person, pallor goes gray. In a brown person, pallor goes kind of a greeny yellow color. So they've actually done studies and shown that people aren't really good at noticing paleness in people of other races. So if a white person were pale, I'd be able to know it pretty well. But if a brown person were pale, it might be harder for me because I'm not brown, right? So if you think, oh, that patient's color is wrong, ask their family. Ask them, hey, do they look pale to you? Usually they'll be able to say, yeah, they don't look right. That's not the right color of their skin. Okay. So pain, pallor, right? Think about the tourniquet again. Eventually, my hand would go really white, right? Because I'm a white person and that's what pallor is for me. Pulselessness. Let's say my tourniquet was here. If it's on long enough, eventually I'm not going to have a pulse here, right? So pulselessness just means lack of pulse. That means blood is not getting there or the nerve is not innervating to get enough blood there. Okay. Paresthesia. Paresthesia is that feeling when you sleep on your hand and then you have to shake it awake and it's that numbness and tingling, pins and needles, kind of hot feeling. Okay. That feeling of nerve issue is called paresthesia. Okay. Now, poikilothermia is probably a word you've never heard. I'm convinced they just made this word up to fit with the 6 P's because poikilothermia just means cold, right? Now, if you go in and you touch a patient's hand and it's cold, you can assume they're probably not getting enough blood circulation there because humans are supposed to be warm. Okay. And then paralysis. If I were to leave this tourniquet on for a week, I'm not going to be able to move my hand, right? So eventually it progresses to there. So do you guys recognize how those 6 P's can lend itself to thinking, oh, there's a blood issue or a neuro issue? Does that make sense? Okay. Questions on that? Pain, pallor, pulselessness, paresthesia, poikilothermia, and paralysis. We're going to talk about them a lot throughout the rest of the semester. So it's good to know those ones.
Are those all blood issues or?
They are blood or neuro or both. So good question there, Kirsten. If there's an issue, if you have pain in your hand, I'm going to assume it's either a lack of blood flow or a lack of nerve. Something's wrong with your nerve, like you have a nervous system issue. Yeah, so neuro or vascular or both. Good question. Okay, let's talk about blood pressure. You guys all know how to take a blood pressure. You know what normal blood pressure is. Let's talk about pulse pressure. Pulse pressure is when you take your systolic minus your diastolic. Okay, pulse pressure for 120 over 80 would be 120 minus 80. So normal pulse pressure is 40. Okay, now if you have a low pulse pressure, let's say your blood pressure is 120 over 100. If that pulse pressure is like only 20 millimeters different, that tells me you've got some sort of diastolic heart failure. Okay, or maybe you're going septic. Okay, if you have a large pulse pressure, let's say your blood pressure is 120 over 30. Oh, that's bad, right? Your body is just leaking all over the place. Okay, so understanding the pulse pressure can be helpful sometimes, trying to figure out what's going on. Okay, so how about my pulse? My blood pressure is 150 over 50. What's my pulse pressure? 150 over 50. 100. Yeah, good job, guys. Okay, orthostatics. Have any of you done orthostatics before or had them done to you? Orthostatics is where you test their blood pressure when they're lying down. Then you sit them up, wait 5 minutes, test their blood pressure while they're sitting up. Then you stand them up, wait 5 minutes, and then test their blood pressure when they're standing. If the blood pressure differences between all three of those are more than 10 millimeters of mercury, we're going to say they've got a heart issue. They are not getting blood to the rest of their body in an adequate fashion. Okay, so orthostatics are really helpful just when we're trying to figure out what is going on. Maybe it's an orthostatic issue. Okay. Now, the last one is, we call it a MAP. It stands for mean arterial pressure. This is the number in parentheses next to your blood pressure. Have you guys seen that? It'll say like 120 over 80, parentheses 65. Now, they do a mathematical equation to figure it out. It's like 2 times the diastolic divided by the systolic, I think. You don't need to know that. What I do need you to know is a MAP is a really good way of looking at blood pressure. Okay. We use MAPs all the time in critical care. The doctor will say, well, what's their blood pressure? And he's not asking, is it 100 over 80? He's asking, oh, what's his MAP? Is it 60, 65? Okay. In the ICU, we want to keep patients' MAPs 60 and higher. Normal people, great MAPs, 65. Okay. If your MAP is in the 50s, you're not getting blood to your limbs. Your blood shunts to the core, feeds your brain, your heart, your lungs, but it's not feeding your fingers or your toes. Okay. So a good MAP would be 65. Questions on those blood pressure measurements? Okay. Let's talk about arterial pulses. You guys know how to check the rate, right? You look at your watch and you count. The rhythm is it danceable? Woo, right? Can you dance to it? Because if a rhythm goes like this, that's bad, right? That could be AFib. That could be VTAC, VFib, right? It could be really bad. So checking their rate and their rhythm. We want a nice, consistent rhythm that you can dance to, okay? The last one is called your amplitude. Your amplitude is how hard is it pushing on your fingers? Have you guys all like exercised before and then you look at your wrist and you can see your pulse bulging out of your wrist? That means it's a big amplitude, right? It's a higher amplitude. So normal pulses, when you're just sitting and resting, you should have a 2+ amplitude. If you cannot feel it, but you get an ultrasound machine and you can hear it, that's a 1+ amplitude. And if you use an ultrasound machine and you cannot feel a pulse, that's a 0 amplitude. Okay. Now, when you exercise really hard and your pulse is bounding and you touch it, you're like, oh, I can feel that really good. That's a 3+ amplitude. So it goes from 0 is pulseless, 1 you need a Doppler, 2 is normal, 3 is bounding. Their heart is pumping real hard. And that can tell us about how strong their heart is. Questions on those pulses? Okay. Last one on this slide for physical assessment is to look at their jugular vein. So your jugular vein is this vein right here, which you should not see on me because I'm standing up and my heart is not broken. My heart is healthy. Okay. So the jugular vein, if you lie them flat, you'll be able to see anybody's jugular vein. That's normal. When you put them up to about 45-degree angle, you should not see the vein. And when you put them up to a 90-degree angle, you definitely won't see the vein unless there's a heart issue. Okay. So if you see the jugular vein pulsing and they're standing upright, that tells me you got a really bad heart. For some reason, all the blood in your head is not draining into your chest, and so much so that all the blood is getting up here and your veins are actually pulsing. Veins aren't supposed to pulse. Arteries are supposed to pulse, right? That's a huge backup of blood if they've got jugular venous pulsations. Okay, any questions on physical assessment of cardiovascular system? Fantastic. Let's do another poll. This is our second poll. It's a select all that apply. Okay, let's do 10 more seconds. Okay, so this is one, I told you I wouldn't ask you this on a test, but I did need to ask you on here so you know some knowledge, right? Get some knowledge across. What are our 6 P's? Pain, pallor, pulselessness, paresthesia, poikilothermia, paralysis. Anybody got any questions? Kevin, yes, absolutely. Okay, awesome. So let's talk about other physical assessments, okay? Now your heart doesn't just affect your heart, which we've talked about. It can actually give symptoms to your lungs and symptoms to your abdomen, okay? So lung symptoms, you could have hemoptysis, which is sputum in your, or blood in your sputum. That could be a lung or a heart thing, right? The heart is just crapped out and the lungs are just backing up and filling up with fluid or pressure, okay? Cough. A cough can be not necessarily just a lung thing. It can be a heart thing. If your lungs are filling with fluid because of left-sided heart failure, you're going to be coughing. Coarse crackles doesn't have to be a lung issue. It could be left-sided heart failure that caused pulmonary edema. Wheezes as well. Wheezes, right? If you've got enough mucus and fluid and stuff built up in your airway, it could be a heart thing causing wheezes. Now, obviously, it's more common to cause lung issues, but if you can't see any lung issues on a patient, look for heart issues, okay? Because they're best friends. So they always have each other's backs until they crap out, okay? Your abdomen. A patient with a right-sided heart failure could have a distended abdomen. The right side of the heart fills up with blood, so it backs up into the rest of the body. So the feet, you get pedal edema, you get edema in your legs, edema in your genitals, and then edema in your belly, which is abdominal distension, okay? This picture is of a healthcare provider testing the patient's hepatojugular reflex. What it is you lie them at about a 30, 45-degree angle, jam your thumbs in their liver. And you have to go up and under the ribs. So it's kind of uncomfortable. So you jam it in their liver, and the liver is essentially a bag of blood. So what you're doing is you're creating a ripple. And if you see their jugular vein get bigger when you jab their liver, their heart can't absorb that ripple of blood, which tells me heart failure. Okay, so this guy has heart failure. You see how big his jugular vein is right there? It's not supposed to be sticking out that big. When we jab his liver, his heart can't absorb that wave of blood, so his vessel pulses. Okay, and then bladder distension. What do you think bladder distension has to do with cardiovascular health? Any ideas?
Your kidneys might not be getting perfused, so they're holding on to fluid.
Yep, absolutely. Kidneys are the first thing to go. Kidneys are like the martyr of the body. They're like, I will die for you, heart. I will die for you, lungs. I'll die for you, pinky toe. They are dramatic. Okay. The kidneys are like the first things, the first organs to crap out. So if we've got bladder distension, it could mean because kidneys aren't getting perfused because we've got low cardiac output for some reason. Also, remember that if you keep your bladder full, your blood pressure goes up. So your body may be holding onto urine just to keep your blood pressure up. Okay, you're not going to be making pee when you don't have enough blood pressure to function in your brain. Okay. Questions? Okay, let's do 2 more slides and then we'll take a break, okay? This next slide has to do with listening to heart sounds, okay? Lots and lots of different heart sounds. Feel free to listen to these on your own time, but we're not going to listen to them, and I do not expect you to know them. Because there was a study where they tested 5,000 cardiologists. So cardiologists, I mean, they're the heart doctors. They should know their crap, right? They had 5,000 cardiologists test patients and listen for heart sounds, and only about half of them got the heart sounds right. How could I ever expect you guys to know what an S4 sounds like if a cardiologist doesn't even know what an S4 sounds like? That's ridiculous, right? So they're there if you want to practice, but what I really want you to know is this one. So I'm going to turn it up. It's kind of quiet. Do you hear that? Turn your volume up, maybe. It's pretty quiet. I've got my volume all the way up. Let me see if I'm, yeah, I am sharing. Okay.
I could hear it.
You could hear it? Okay. So this, and if you can't hear it, it's a normal heart sound. This is S1 and S2. 1, 2, 1, 2, 1, 2. This is what I want you to know. If you listen to a patient and it does not sound like this, that's when you tell the doctor, hey, we've got some weird heart sound. And he'll say, okay, let me go look. And he may or may not guess right what it is, but then we'll get an echocardiogram. An echocardiogram is an ultrasound of the heart that you can see the valves moving and the blood moving and listen to the heart rate at the same time. So it's really good. So whenever you hear an abnormal heart sound, request that the doctor get an echocardiogram. Okay. But really, this is S1 and S2 are normal, everything else abnormal. Okay. Questions on heart sounds? Okay. So prioritizing. Depending on where you are in the hospital, your priorities change. Okay. So let's say we have a patient with chest pain, comes to the ER. The first thing the ER nurse is going to do is going to say, okay, what's going on? History of chief complaint. If they say anything related to heart health, we'll do an EKG first thing. Okay. Because an EKG can rule in or out cardiac arrest. No, not cardiac arrest. Well, it can be that, but I meant heart attack, myocardial infarction pretty easily. Okay. And then the ER nurse is going to give a really focused assessment, just the cardiac. Okay. Kind of look at their 6 Ps, listen to their heart, listen to their lungs. Now, let's say that same patient, we decided he is having a heart attack. Maybe we send him to cath lab, or maybe we just send him straight to the ICU, depending on how bad it is. ICU, the first thing the ICU nurse is going to do is hook them up to everything we've got, because ICU nurses love data. We want all of this information so we can puzzle it out and figure out what's going on. So we're going to hook them up to telemetry, which is the heart leads. Then we'll do another EKG. Not because we think the ER didn't do it right, but because we want to compare, is the heart getting better or worse from what it was in the ER? Okay, so we'll do another EKG. Then we'll do a full physical assessment. And I'm talking like, we're going to be so thorough that we're looking in this patient's butthole, right? ICU nurses, we got to look everywhere. Like I said, we love our data. Okay. Then we'll take a full health history. I want to know if you had strep throat when you were 3. Like that's how in depth this ICU patient's history should be. Okay. Okay. So let's say the patient's getting a little healthier. Then they go to a telemetry unit. Telemetry nurses, again, first thing we're going to do, telemetry nurses will hook them up to cardiac monitoring. Okay. To telemetry. Then they'll do an EKG. Again, this is just to compare. Are they getting better from the ICU and from the ER? Okay. The telemetry nurse will do a physical assessment. It's probably not going to need to be as thorough as the ICU nurses because 1, how many times do you need to look in a person's butthole to know it's not changing, right? But 2, telemetry nurses have a lot more patients. They're a lot less sick of a patient. And so you're expected, your physical assessment is a little less thorough. That's normal. That's expected. Then they'll take a health history, which probably is just going to encompass, hey, I saw the ICU nurse miss something. Let me answer this question, right? Now, let's say the patient's about to go home. They got even healthier. Then they move to the med-surg floor. The med-surg nurse, the first thing the med-surg nurse is going to do is a quick physical assessment, where med-surg nurses are essentially saying, are you going to survive if I walk away for an hour? Like that's how it is. Just real, listen to heart, listen to lungs, look at their pupils, they're good. Okay. The med-surg nurse would probably ask a couple of health history questions. Why are you here? Are you a smoker? Like what led you to this kind of thing? And then the med-surg nurse will actually prepare the patient for discharge. And there's a lot of stuff that goes into discharge. So med-surg nurses are pretty busy. Plus they have like 5 to 7 patients. But do you see how where you are changes what your priorities are? And that's completely okay. Completely okay. Because if you're here, we're worried about what's going on. If you're here, you're very sick. We know what's going on, but you're very sick. Here, you're less sick, and here, you're practically healthy. Okay. Questions on prioritization? Wonderful. Okay, let's take a break. It's 10:57. I'll start talking again at 11:07.
Tumble out of bed and I stumble to the kitchen, pour myself a cup of ambition and yawn and stretch and try to come to life. Jump in the shower and the blood starts pumping. Out on the streets the traffic starts jumping with folks like me on the job from 9 to 5. Working 9 to 5, what a way to make a living, barely getting by. It's all taking and no giving, they just use your mind. Give you credit, it's enough to drive you crazy if you let it. 9 to 5 for service and devotion. You would think that I would deserve a fair promotion. Want to move ahead, but the boss won't seem to let me. I swear sometimes that man is out to get me. They let you dream just to watch him shatter. You're just a step on the boss man's ladder, but you got dreams he'll never take away. In the same boat with a lot of your friends, waiting for the day your ship will come in and the tide's gonna turn and it's all gonna roll your way. Working 9 to 5, what a way to make a living, barely getting by. tears cry. And the minutes turn to hours, and they're flying like a jet plane. And we'll make it right tomorrow, but tomorrow's not a sure thing. The clock don't stop ticking away. Yeah, 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 yeah. The clock don't stop ticking away, away. Always hanging on the wall. No, it don't care at all. And we'll slow down and we'll wait. The clock don't stop ticking away. It's ticking away. Head scared, heart broke, burned from a band of gold. Rather just be alone. It's just a bad joke. Bang, bang on a drum. You're not a setting sun. You ain't even close to done. Run, baby, run, 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 run. The clock don't stop ticking away. Yeah, 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 yeah. The clock don't stop ticking away, away. Always hanging on the wall. No, it don't care at all. And we'll slow down and we'll wait. The clock don't stop ticking away. It's ticking away. Yeah, yeah. Red dress, spilled wine, caught in a stupid fight. I'm wrong, you're right. Kiss me goodnight. The clock don't stop ticking away. Yeah, 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 yeah. The clock don't stop ticking away, away. Always hanging on the wall. No, it don't care at all. And we'll slow down and we'll wait. The clock don't stop ticking away. It's ticking away. Yeah, clock don't stop ticking away.
Six o'clock on Friday evening, mama doesn't know she's leaving till she hears the screamer slamming, rubber squealing, gears are jamming, local country station just a blaring on the radio. Pick him up at 7 and they're heading to the rodeo. Mama's on the front porch screaming out her warning, girl, you better get your red head back in bed before the morning. 9 o'clock, the show is in, but the fun is just beginning. She knows he's anticipating, but she's gonna keep him waiting. Grab a bite to eat, and then they're heading to the honky-tonk. But loud crowds and line dancing just ain't what they really want. Drive out to the boondocks and park down by the creek, where it's George Strait, relate and dancing cheek to cheek. Ain't going down till the sun comes up, ain't giving in till they get enough. Go around the world in a pickup truck. Ain't going down till the sun comes up. Was wine and dancing, midnight starts a hard romance, and 1 o'clock that truck is rocking, 2 is coming, still no stopping, break to check the clock at 3, they're right on where they wanna be, and 4 o'clock get up, get going, 5 o'clock that rooster's crowing. Sun comes up, ain't giving in till they get enough. Go around the world in a pickup truck. Ain't going down till the sun comes up. o'clock on Saturday. Her folks will know he's on his way.
Okay, guys, come on back. Flip your cameras back on. Okay, anybody got any questions that you thought of over the break? Okay, so now let's talk about how to diagnose heart things, any heart abnormality. As you can see, there's a lot of different diagnostic tests, and we're going to talk about each one. Okay, so let's start with labs. We have non-cardiac specific labs first. These ones, like potassium and red blood cell count, these ones don't mean you have a heart issue, but if they're problematic, it can cause a heart issue. So for example, if your potassium, let's say, is 10, that leads to cardiac dysrhythmias, which can lead to cardiac arrest. So it's not like you have a heart problem because your potassium's high. Could be a kidney problem, probably. But if you have a high potassium, it's going to cause a heart problem. Okay, that's what I mean by non-cardiac specific labs. And then red blood cells, your red blood cell count, if it is low, that means you don't have enough blood. And when your heart doesn't have blood, it's like, finally I can stop. And you go into cardiac arrest. So you don't have a low red blood cell because of your heart issue, but your low red blood cell issue will cause a heart issue. Okay, those two make sense, how they correlate with the heart there? Okay, so now the cardiac specific ones. These ones directly are happening because of heart health. Okay, troponin I. Oh my gosh, Riley, that kid is adorable. So troponin I is a cardiac marker for heart damage. Okay, if you have any troponin in your blood, because you can see normal is like less than nothing almost. If you have any, he found the space bar. If you have any troponin in your blood, it means you have heart muscle damage. Heart muscle damage is almost always heart attack. Could be pericarditis, and we'll talk about how to differentiate between those two. Or it could be you got like severe trauma on the chest, like you got punched right in that chest really hard or something. Okay, but any troponin I in your blood means you have heart muscle damage. So troponin I can only be seen in your blood after 2 to 3 hours. So if you have chest pain and you go to the ER and you say, I've had chest pain for 10 minutes, they'll draw this, but you'll see nothing. But then they'll draw another one 6 hours later and you'll see it elevated. And then 6 hours later, and it's going to keep going up for 24 hours. So the peak is 24 hours on troponin. But then troponin will stay in your blood. It'll start going down for 7 to 10 days. Now, let me tell you the reason you want to know these numbers. If you're taking care of a patient with a heart attack, and let's say you're a night shift nurse, because all of you are going to have to work a night shift at some point if you're taking care of a cardiac patient, right? So let's say they got admitted at 8 at night. 6 hours later, they test their blood. So what's 6 hours later? 3 a.m., 4 a.m.? Anyway, it's middle of the night. And their troponin is at a critical level. Do you think I'm going to call the doctor and tell them my patient has a critical level of troponin in their blood at 4 a.m.? No, the doctor knows troponin goes up. I don't want you to get yelled at for calling them for no reason at 2 a.m. or whatever. Okay, that's why I want you to know it's going to keep going up. That's anticipated. After 24 hours, it should start going down. If it keeps going up after 24 hours, no matter what time of day it is, that's when you call the doctor. Okay. This is also helpful if someone comes in and is like, oh, I was having really bad chest pain yesterday, but I couldn't do anything because I had to be at work or whatever. Now I came in, we can test the troponin. We're like, yeah, you had a heart attack yesterday. Okay. So troponin I is a fantastic indicator of heart attack. Almost always it's heart attack if you have troponin I in your blood. Okay. Questions about troponin?
I have a question.
Go for it, Brianne.
So the more severe the heart attack or the more severe symptoms, like if someone's just chilling at work and they have chest pain, and is it just like a less severe heart attack?
Yeah, or it could be heartburn or something, obviously. But if it is a heart attack, less severe heart attack leads itself to less severe symptoms. Yes, that's a true statement. Good job. Any other questions about troponin? Okay, so lipid profile. These are essentially a measurement of your cholesterol, which I like to think of as, here's my arteries in my body. The more cholesterol I have, the more clogged these arteries become. So it makes sense because lipids increase your pulmonary and systemic vascular resistance, therefore increasing your heart's workload. And when your heart works out, it gets buff, which is not good for your heart. You don't have enough room to get buff in here. It's like those guys who have such big biceps, they can't even like touch their shoulder. Your heart can't properly contract if it's thick, right? So looking at your lipids can help you assess your hypertension and your risk for cardiac issues. So LDLs, you want them low, okay? L for low, L for LDLs. HDLs, you want them high, right? HDLs, H, okay? So remember, LDLs are the bad ones because you want them low, and HDLs are the good ones because you want them high, okay? The last one is your BNP, not BMP, not basic metabolic panel. Basic metabolic panel is like sodium, potassium, chloride, glucose, stuff like that. It's not that. BNP stands for B type, which is brain type, which makes no sense to me because this is a heart thing. B type natriuretic peptide. If you have a BNP over 100, this tells me your heart is stretched out. And when your heart is stretched out that much, you're in heart failure. So this is a heart failure lab. If you suspect your patient's in heart failure, you're going to draw their BNP and it's probably going to be over 100. Okay, so just remember 100 for BNP. Below 100, no heart failure yet. Above 100, heart failure. Okay. Questions about these labs? Riley, does your son have a question? He's raising his hand. Just wanted to be cute. That's allowed. That's allowed. Okay, so let's do a poll question. Let's see how well you understand. Whoops, wrong one. Let's see how well you understand what we were talking about with troponin. So give that one a try. This is the classic nursing school question. There's one answer that's right and one answer that's more right. Okay, let's do another 10 seconds. Okay, so what does troponin measure? A. Heart muscle damage after 2 to 3 hours. Okay. Now it also measures heart muscle damage after 24 to 48 hours. But wouldn't you rather know at 3 hours that you have heart muscle damage than at 48 hours? So C is right, but A is more right. Okay. B, generalized muscle damage. It's not generalized. It's specifically cardiac muscle damage. So troponin is a protein on the outside of your heart. So it's this little protein hanging out outside your heart. When you have a heart attack, your heart muscle kind of like starts to die and it'll flick that troponin into your bloodstream. Troponin is on no other muscle. So we know specifically it is cardiac muscle damage. Okay. And then the last one, immediate generalized muscle damage. Troponin is not immediate and it's not general. It takes 2 to 3 hours and it's specifically cardiac. Makes sense why A is the answer. The best answer. Any questions? Awesome. Okay, let's keep going. Let's talk about electricity of the heart. Lots of different ways to look at the electricity of the heart. The first thing you can do is a hardwired continuous monitor. This is what you see in the ERs and the ICUs. This is when they're connected to cords that are connected to the wall. That's called continuous monitoring. They're usually either a 3-lead or a 5-lead. Okay, this means you usually have 3 stickers or 5 stickers. ICU, always going to be 5 stickers. ER, sometimes 3 stickers. They're trying to get to 5 because the more stickers you have, the better look you get at the heart. Okay. Okay. Now, telemetry, portable telemetry, this is done on a tele unit. This is a box that you wear in your pocket so you can walk around. You're not connected to the wall like you are with continuous monitoring. Okay. So this one is always a 5 lead. And I'm going to teach you in just a little bit where to put the stickers on the chest for that 5 lead. Okay. Now an EKG, which stands for electrocardiogram, it's also called ECG because cardiac starts with a C. EKGs were invented in Germany though, and cardiac in German starts with a K. So you'll hear me say EKG. That's what I always say. But like if you've talked to Dr. Greg before, he always says ECG, and they're the same thing. EKGs and ECGs are the same thing. Okay. So a 12 lead EKG is when they have to bring in that little cart with a computer on it. They hook up 10 stickers and 10 wires, and they get this kind of printout. It prints a 1-pager about what's going on with the heart. Okay, so this is a 12 lead EKG printout. These two are seen on the monitors at the nurse's station or in the room, the patient's room. Okay, this one you have to bring the computer in and print it out. These, all 3 of these, help identify arrhythmias. They help look for heart attacks, okay? And they're useful for comparing. Remember we talked earlier about how the tele nurse is going to do an EKG when the ICU nurse already did the EKG, when the ER nurse already did the EKG. We compare them and see if they're getting better, okay? Okay, the next type of electrical monitor is the Holter monitor, okay? The Holter monitor is like this. It's worn around the neck, or there's the kind that you can like hook on your belt area, okay? And the patient will wear these for 1 to 2 days or like a full month, okay? Have you guys ever been like sick, schedule a doctor appointment, by the time you get to the doctor, you're like, well, I'm not sick anymore, right? This is for those guys. They say they're having heart palpitations or heart issues. They go in, we do these things, don't see a dang thing, but we send them home with a Holter monitor. And so what happens is they wear it for a couple of days or even a month. And every time they have that weird sensation that they couldn't recreate at the doctor's office, they'll press this button. It'll create a little flag. Then they send this to a company to read 1 to 30 days worth of EKGs. Okay. And where all those little flags are, we'll look, oh, well, the reason the patient was having heart palpitations is because they went into a route of VTAC or whatever. Let's see, have someone say they had to wear it for 2 weeks. Yeah. So it's really depending on what the doctor thinks it is, any span of time in that area. Okay. For this, you need to teach the patient where to put these, because you can't wear these for 30 days. They will rip your skin. They will destroy your skin. Okay. You need to be able to take them off, take a shower, put them back on. So you got to teach the patient where they go on the body because the colors matter. If you put the colors in the wrong order, you're going to get an EKG that looks real weird or real deadly when maybe it's not. Okay. So the way to remember where to put them, white on right, patient's right, which is our left. Okay. As a nurse, you're going to learn you got to convert everything backwards. And it's going to get really confusing when you're not supposed to convert things backwards. Okay. So you're going to flip everything. Left is right and right is left because you're looking at your patient. Okay. So white on right, the white one can go anywhere in this green box, anywhere in this area. So if they have it on, then they take a shower. When they put it back on, they can put it here or here or here or here or here. We want them to rotate because these stickers, like I said, are really bad on your skin. Okay. So white on right, snow over grass. So when it snows, the snow is on top of the grass. So snow over grass, white over green. Green goes down below white. And green can be anywhere in that green square. Anywhere in this area, all the way to the hip, just under the nipple line through the midline. Okay. Our other one is smoke over fire. Do you guys remember when you were little and elementary school like trained you to crawl under the fire smoke, right? Because smoke rises. So black over red. So black goes up here in this box, anywhere in that area. Red goes down here in this box, anywhere in that area. Okay. And then the last thing is super cheesy. I hate it, but it makes you remember it. Chocolate melts the heart, right? So brown goes in the middle because your heart's in the middle. So brown just needs to be in between. If you made it like a box with all the other four, brown just needs to be in there. So brown could be in here. Really, I put brown wherever the patient is least hairy, right? If they've got a ton of chest hair right here, it's not going to stick very well. So I'll like tuck it under their chest tissue or something like that. Okay. You got to teach the patient also to rotate it, right? We don't want to leave it in the same place for 30 days and to watch out for their skin integrity. Okay. And this is how you not only hook up a Holter, but you also hook up your continuous monitor and your portable telemetry. Any 5 lead is going to be hooked up like that. Questions? Okay, let's keep going then. Let's talk about an echocardiogram. This was an electrocardiogram, electricity. Echocardiogram is having to do with sounds. So echo is a sound, right? That's how I remember that one. So echocardiograms are ultrasounds of the heart. There are 2 different ways to do this. One is the transthoracic echo. So it's called a TTE, transthoracic echo. All we do is do an ultrasound on the heart, just like we're looking at a baby. It's not invasive. Well, your shirt is off in front of a stranger. I mean, that's a little invasive, but it's not going into the body, right? So you just do an ultrasound on here. They, super easy, okay? Now, a transesophageal echo, TEE, because your esophagus, it goes down your throat. This one is actually an ultrasound probe that goes down your throat and it looks at your heart from the back. It does an ultrasound of the heart from the throat, from the esophagus, okay? Now, the reason you would want to do this, if you have a patient that has a lot of chest tissue, either they're obese or have big breasts or both, this isn't going to work. It's hard to read through a lot of fat tissue. So we'll do this instead. This is also not a good choice if they just ate. Because like I said with the bronchoscopy, they say they don't have a gag reflex 6 feet in or 4 feet in, they do have a gag reflex, right? We don't want them to gag, aspirate, puke, aspirate pneumonia, dead, right? We don't want to do that. So if they just ate, this is not an option. You got to do the TTE, okay? And this is what it'll look like. So I don't expect you to be able to read or look at what this is, but this is one of your ventricles. There's a valve, and it shows blood movement. It shows if the blood is oxygenated or not. It shows valve movement, and you can hear the heartbeat at the same time. So this is what we do when you hear something weird in their heart sounds, and you're like, Doc, let's get an echo. Because this is going to tell you, oh, it's a mitral valve issue, because it's the mitral or whatever valves I'm looking at. This is probably the left ventricle is my guess. This is probably aortic valve and mitral valve, but the echocardiogram can show you all that, okay? What it's also going to measure is your ejection fraction. So your ejection fraction is the percent of blood that's in your heart that leaves when it pumps. So let's say, just for the sake of easy math, you have 100 mils of blood in your heart at all times. When you contract, about 55 to 75 mils comes out. A good ejection fraction is 55 to 75%, okay? If you got 100% of your blood out at one time, your heart would stop and be like, okay, I don't have any blood. I'm going to stop moving now. That's not a good thing. So we always leave a little bit of blood in the heart with every heartbeat. That's normal. Now, the reason we do echoes are usually to diagnose, like, how bad is their heart failure? Because an ejection fraction, the closer you get to 0, the closer the patient is to dying. I took care of this woman with a 12% ejection fraction, 12%. So her heart was 12% efficient, which is terrible. I think she died within like 2 days of heart failure, right? So the closer your ejection fraction is to 0, the closer your patient is to death. 55 to 75 is where most of us probably are. Oh, Blair saw someone yesterday with a ejection fraction of 11%. I'm guaranteeing that patient's not going to live long without a heart transplant, right? Oh, that's rough. It also looks for valvular function. So it can tell you if you're having like a valve prolapse or a valve stenosis. Okay, so that's helpful. And then nursing interventions. Before we do this test, the doctor may ask us to hold all their cardiac meds. Why do you think that would be a thing? Why would we want to hold their cardiac meds when we're doing an echo?
Is it because you want to see their baseline of their heart?
Yeah, you want to see what their heart's doing, not what the meds are doing to the heart, right? We want to see how really sick they are, not having the meds cover up the symptoms. Very good. Questions about echocardiograms. Okay, one way, a student told me this, one way to remember which is which on these, you drink tea, right? So the TEE goes down the throat. If that helps you, great. If not, forget it. Okay, so let's do another poll. Try that one. Okay, let's do another 10 seconds. You guys are answering this one fast. Awesome, we got everybody. Okay, which echo is most invasive? Well, C and D aren't even echoes. So get rid of those two, right? So A or B is your answer. So transthoracic goes outside, transesophageal goes inside. So the answer is B. Transesophageal is the most invasive echo. Majority you've got that right. Anybody got any questions on that? Good job. Okay. Now let's talk about a stress test. A stress test is exactly what it sounds like. We stress the heart to see what it does when it's stressed out. Because some hearts can be fine when you're not stressed. And then as soon as you get stressed, they go crazy. Something happens, right? So this test, usually it's done on a treadmill. The person is walking on a treadmill. We hook them up to a 12-lead EKG. As you can see, he's got a bunch of stickers here. The nurse is monitoring vital signs. The doctor is looking at the EKG rhythms. And we make the person sweat. We give them vigorous exercise. I'm talking like 12% incline, aiming for a heart rate over 180. Like we are stressing their heart, okay? You will stop this test once the patient reaches their target heart rate, but that's determined by the cardiologist. It has a lot to do with age, weight, disease processes, comorbidity, stuff like that. So the cardiologist will decide what that number is. But once they reach that heart rate, then we stop the test. We will also stop the test if they have any chest pain whatsoever. Even if the patient says, I have some chest pain, the nurse says, well, what's the number? And the patient says 1. It's pretty nothing. We will still stop the test because 1 out of 10 chest pain could mean heart tissue is dying. It could mean you're having a heart attack. Now, if the patient says, I have toe pain, and they say 1 out of 10 toe pain, I'm like, keep going, dude. I don't care if your toe hurts right now, right? But chest pain is different. Chest pain, you have to take seriously no matter what the number, okay? So if they got chest pain, we'll stop the test even before they get to their cardiac heart or their set heart rate. We will also, the third reason to stop the test is if they have EKG changes. If the doctor sees something, that's all we needed, right? The doctor needed to see what was happening. So if he sees something change, then we will stop the test, okay? So 3 reasons to stop a stress test. They hit their target heart rate, they have any chest pain, or they have any EKG changes, okay?
I have
Now,
a question.
Yeah, go ahead, Kirsten.
So like when I work out or if I haven't worked out for a long time, like my chest will hurt really bad. So it's kind of normal. So do you always have to stop it?
You would have to stop it, but the doctor would take into account maybe you have a little like exercise-induced asthma or something like that, right? And so they would take that into account. But usually the people doing this are not healthy young people. They're unhealthy older people, okay? And so you're an exception. right? The people that we're doing this to wouldn't have that sort of exception usually. And if it was, that's something that the doctor and the patient would have to decide if they're willing to risk. If you're really having a heart attack, we should probably stop this. But most heart attacks you can see on EKGs. So we could stop that for EKG changes, right? Good question, Kirsten. Okay. Now, like I said, most of the people that get this done are not that healthy. In fact, some of them couldn't walk on a treadmill, right? Can you imagine a person who's having heart issues that maybe they're so big their hips are wider than this treadmill? Or they're so big they physically can't lift their own body weight? Or they're a paraplegic? Or they're an amputee? Or, you know, all these reasons. There's lots of reasons some people could not walk on a treadmill for that long, okay? In that case, we will do pharmacologic stress test. We give them a drug that accelerates their heart, and we see if there's any EKG changes. The thing is, we don't like that one as good. We don't like that one as good. We don't like that one as much, because if you're having a treadmill test and you get chest pain, we just sit you down. But with the drugs, there's not an antidote to these drugs. So there's no just sitting you down and your heart will slow down. We have to wait till the drugs get out of your system for your heart to slow down. So pharmacologic options are not our first choice. We would much rather have the patient exercise, okay? For treadmill or for the farm stress tests, you need to be NPO 3 hours before. One, because the drugs, if you do the farm, the drugs upset your stomach, aspiration pneumonia, death, right? But do you know, this is not me, but do you know there's people out there that exercise so hard they vomit? I've never been, that's never happened to me, but apparently that's a thing. So that's why NPO 3 hours before, because we're really going to exercise them hard. We don't want them to puke, okay? Questions about the stress tests. Okay. Now, this is the next step up. Maybe the stress test showed us something weird or didn't show us something. So we need the next step up, the next more invasive test. So this would be a nuclear scan, also called a SPECT scan or a PET scan. Okay. So what they do is they give you some drugs, and some of them have radioactive isotopes in it. It's a dye. Okay. And then your NPO for 3 hours, but then you lie down in this PET scanner and they scan how your heart and the dye works. This is what it looks like. I don't expect you to be able to read this at all, but this is what it looks like. And they're going to stress your heart. They're going to give you the same pharmacological drugs to stress your heart because you're just lying on a bed. They stress your heart and they look and see where's the blood going, what's happening in there. Okay. Again, this test, you're going to stop for the same 3 reasons that you stop the stress tests. Okay. If they hit their target heart rate, the test is over. If they get chest pain, the test is over. And if they get EKG changes, the test is over. Okay. Questions about either of those?
For this one, you said they use a dye, right?
Yeah,
So we'd
it's a
have to-
contrast. Mhm.
Okay, so for like nursing considerations, we'd have to make sure they're not allergic.
They're not allergic. They don't have kidney issues. They don't have pancreas issues. Absolutely. Yeah. If they can't process this dye, they're not getting this test for sure. Good critical thinking skills there, Dominique. Thank you. Any other questions? Okay. The next set of diagnostic tests are called angiographies. Okay. Angio is your vessels. Graphy is to take a picture of or to look at. Okay. So we're looking at your vessels. There's 3 different types of angiography. We've got CT angio. You guys heard of that term, a CT angio? It's just a CT scan of your vessels. Okay. Then we'll talk about right heart cath that uses fluoroscopy to look, and a left heart cath that uses fluoroscopy to look. Okay. So this is what a CT angio looks like. They have special software in the CT scanner, and it looks at your vessels. It's less invasive than normal angiography, which we'll talk about in just a second. That's your left and your right heart caths, because it doesn't break your skin. Left and right heart caths do break your skin. Okay. So this just takes a picture, a 3D rendering of your heart. It kind of looks like those pictures you can get of your baby before it's born, right? It's that same sort of technology that does that. But the thing is, is you're still getting radiation because it's still radiation, right? A CT scanner has radiation. And all you're doing is seeing the outside of the vessels. Okay. Outside of the vessels doesn't really help you if there's a clog in there. If it's a new clog and it hasn't changed your vessel size, it's not really going to help you. But if I look at these vessels and I see there's a narrowing and it's really fat up here and really skinny down here, that can tell me there's a clog, right? So a CT angio is considered less invasive, but it still has risks. And it's only showing you the outside of the vessels. Okay. Questions about CT angios? Okay, let's move on to right heart catheterizations. Okay, right heart catheterizations are when they take a catheter, which is essentially, it's like a long, thin straw. Okay, it's like 5 feet long. They insert it into your vein. We would prefer the radial vein. Our other options are the brachial vein or the femoral vein. The reason we prefer the radial is it's easy to access in the cath lab, and we don't want the femoral because whenever you cut into the femoral area, you're at risk for more infection because your femoral area is right next to your bacteria-ridden genital area. And we don't want that bacteria to go from your labia to the hole in your vessel and then to your heart and you die, right? So we would avoid the femoral area at all costs, okay? So we try and do radially. We insert it into a vein. So if I insert it into the left vein, the left radial vein, gonna go up, it's gonna into my superior vena cava, right heart cath, or right side of the heart, just like this. So it goes, okay. Right ventricle up into the pulmonary artery. The point of this is it can look at the pressure and oxygen of all of these body parts. So this is a way we can do hemodynamic monitoring. We do a blood pressure from the inside of their vessels, okay? So the reason we do right heart caths is to diagnose pulmonary hypertension. If we stick this catheter in here and it says the blood pressure in your pulmonary artery is really high, we would tell you you have pulmonary artery hypertension, okay? And it goes through all of this. So the inferior vena cava would only happen if we do the femoral approach, which, like I said, we don't like doing. So the superior vena cava, the right atrium, the right ventricle, and the pulmonary artery. It's going to test the pressure and the oxygen of all those areas, okay? We can also use contrast. So once the catheter gets in here, we can shoot them with contrast, still thinking of those nursing considerations that Dominique brought up, because it is contrast, right? And we can put them under fluoroscopy and we can see how far does the contrast go. Does it stop dead in its tracks? Well, there's a clot there or an occlusion there, right? This one can be removed when we're done, or if they're coming back to see me in the ICU, I tell the cath lab to leave it in. Because if we leave it in, we will do, it's a central line that we can do central venous pressure monitoring, CVP monitoring. So it can test the pressure in the pulmonary artery and the pressure in the vena cava. Okay, so it's just more blood pressures, more data. Us ICU nurses, we love the data. We want all the information we can possibly have. So let's talk about hemodynamic monitoring, okay? This is taking blood pressures. We're just not taking them all the same way with the cuff on the arm, okay? So a central venous pressure is what we were looking at here. There's a sensor right here that would tell me the pressure in this superior vena cava. That's a central vein, okay? Central venous pressure. This pressure should be from 2 to 6. Now normal blood pressure is 120/80 because the artery has a pulse, right? So 120 before the pulse and 80 after the pulse, systole, diastole. Veins don't have pulses, healthy veins. So they only get one number. So a healthy CVP would be something like 4. If their CVP is 1, then I know they are hypotensive in their central vein. So I'm going to go with that. Well, what would cause someone to be hypotensive? Maybe they're fluid volume deficient, right? Maybe they're dehydrated. Maybe they are bleeding out, right? That it just gives me more information to look, okay? What if my patient's CVP was 20? Well, that means they're hypertensive. in that area. So what causes me to have hypertension? Well, fluid volume overload, stress, heart conditions, like all this kind of stuff, right? So does it help you to see that this is just blood pressures? It's just in the vein instead of an artery. Okay. We can also, there's also a sensor on the end. So there's a sensor up here in the vena cava, but there's also a sensor on the end. And that would be your pulmonary artery pressure. We call that your PAP or your SWAN. SWAN is the brand name for this catheter. The very first one was called a Swan-Ganz catheter. So that's why some people still call it a SWAN, even if it's not a SWAN brand, okay? So your pulmonary artery pressure, it is an artery, so it has two numbers. So you should be somewhere between 15/20 to 8 systolic and from 5 to 16 diastolic. If these numbers are on the high end, your patient has pulmonary hypertension. If these are on the low end, they have pulmonary hypotension. And you look at it just like you would before. Well, what causes hypertension and what causes hypotension? Okay. Now there's one more measurement that this catheter can do. It's called a POP or a wedge pressure, PAWP. What happens is we blow up a balloon and we completely occlude this pulmonary artery. We don't do it for long because that would be deadly, right? But we blow up the balloon and we measure how much blood is like pushing against the balloon. Since we're blowing up a balloon, it stops the pulsing of the artery in that area. So it's only one number. We want the pressure of the wedge to be 6 to 15. If it's low, they're hypotensive. If it's high, they're hypertensive. Then you have to remember to pull the air out of the balloon so that now blood can get past the pulmonary artery again. Or, dead. So it's important to remember that one, okay? These are all happening on a central venous monitor or a right heart cath. Questions? Everybody totally gets CVPs. Or you're so overwhelmed you can't even think of a question right now. That might be that, right? Okay. Okay, so this is a CVP set up. It goes into the patient, right? And this one, it looks like they're going in centrally, but lots of times they'll just go in radially. There's the balloon I was telling you about for the wedge pressure. Here's the monitor. So this machine hooks two cords that hook to the monitor. It's hooked up to a pressure bag. Anything that goes into the artery needs a pressure bag. Otherwise, the arterial blood will come into it. And we don't want the blood coming backwards. We just want to leave it in the vessel. So we put this pressure bag on it. These are called transducers. You can actually open them up and get blood out. You're not going to for a CVP, but this is the same way an art line works. These transducers, okay? Okay, so an art line is just like a CVP, except it's not in the heart. It's in an artery, usually the radial artery. The catheter, instead of being 5 feet long, is like an inch long. So a doctor or a respiratory therapist it's like an IV in the artery. They'll put the IV in the artery and they'll leave it there. And this will measure their blood pressure moment to moment. Because do you know your blood pressure goes up and down all day? When you're talking, your blood pressure goes slightly elevated. When you're sleeping, your blood pressure goes lower, right? So your blood pressure is going like this. Every second, your blood pressure is slightly different. And an art line can measure that. They can also do it in the femoral artery. But again, we don't like the femoral artery because your genitals are dirty. Even if you're cleaning them regularly, which you should be, your genitals have normal bacteria that we don't want in the blood, okay? So an art line is measuring your radial artery blood pressure, which should be 120/80. That's our normal blood pressure, right? So if you see an art line blood pressure that's really low, we know they're hypotensive for whatever reasons hypotension is. And if it's really high, we know they're hypertensive. Okay, so it's just another blood pressure. Okay, so all of these things, either a CVP or an art line, you need to monitor them to make sure they're giving you accurate results. Because just like the pulse ox, they can give you lies. Okay, so to make sure they're giving you the right information, you'll look for a good waveform. See this waveform here? Nice up, down, up, down. That's what a waveform should look like. If it's all jaggedy or looks more like an EKG, that's a bad idea. That means it's not giving us a good waveform. So if it's a good waveform, it's just like your pleth. You can believe it if it's a good waveform, okay? Every shift, you are going in, and every time the patient is disconnected, so if they have to go to the bathroom, you have to disconnect them from the wall. So every shift at least once, and every time they're disconnected, you are going to zero these and flush these. To flush them, you just pull this little pigtail right here and it'll flush fluid through it. Easy peasy. To zero them, you're going to open the transducer, press the button that says 0 up here, wait for a 0 blood pressure to show up, and then close the transducer. That's just kind of the way of repressurizing it so that we know it's reading. Now, if you do not become a critical care nurse, you're not going to have to worry about doing these. But if you're a critical care nurse, you're going to need to know. So I was in the ICU for a long time, and the ER set one of these art lines up, and they call me and they're like, I don't remember how to do this. Can you come and do this art line for me? So if you don't remember, there's always someone to help you, but ERs do it too. So ERs do have to deal with this as well, okay? Okay, how you feeling about right heart caths?
I have a question for the pressure bag.
Go for it.
Order that you have the pressure set to a certain.
Good question. No, we just pressurize the heck out of it. We put it as high as we can get. Yeah, highest pressure you can get there. Good question. But yeah, it's just kind of a normal setup that you get a pressure bag and you pump it into the green area. The pressure bag has like a red, a green, and a yellow. You pump it into the green. Because if it loses pressure, blood is going to start creeping back up the tube, and then it's going to clot, and then it's going to be useless because you can't read the pressures.
I guess I was more so like worried about if it was too high.
Oh, no, you can't get it too high. No. If you get it too high, you get a little bit of saline into their heart, which is fine. Because this is sterile saline. Good question. Good thinking, Dominique. Anybody else got any questions that you can articulate at this point? Okay. Now let's talk about left heart caths. Left heart caths go into an artery. Remember, right heart caths went into a vein. Left heart caths go to an artery. I had a past student tell me the way they remember this. You take an RV to LA. Right goes in a vein, left goes in an artery. Okay. RV, right vein, left artery. Okay. So we're going to go into the radial artery. And it is going to come, and like here they put the femoral artery, but again, we don't want the femoral artery if we can avoid it. Ideally, it's the left artery. It'll come through one of the branches into the aortic arch, go down into the left side of the heart, into the left ventricle. But before they hit the left ventricle, they can actually go over into the coronary arteries, because the coronary arteries branch off right before the aortic arch does. Okay. So they can look at the blood inside the aortic arch and the branches, inside the coronary arteries, inside the left ventricle, and takes a look at the aortic and the mitral valves. Here we're going against the flow of blood. So we're tracing a drop of blood backwards with a left heart cath because we're going against arteries, right? And arteries go away from the heart. The reason we would do this, one of the most common reasons we do this, is to look for coronary artery patency. We want to see how open your coronary arteries are, because if they're nice and open, good. If they're clogged with plaque and atherosclerosis, this means you're about to have a heart attack, right? Because that's where a heart attack happens. Your coronary arteries get occluded. Okay, that's the only way you have a heart attack, because now the heart can't feed its own muscle blood, which means it starts to die and can't do its job. Okay, so this is a really good look to see if they're having a heart attack, or while they're in there, we can actually fix a heart attack. Okay. We use contrast with this because, again, the contrast highlights the blood. And if the contrast stops, we're like, okay, well, that's where the clog is, right? Because that's where the blood stopped. And then we always take this one out when we're done. There's a really cool video here about a left heart cath. If you want to visualize that, feel free to take a look at that. It's pretty neat. Okay. So now let's compare right heart caths versus left heart caths. Right heart caths go in a vein, left heart caths go in an artery. Right heart caths are usually used to diagnose pulmonary hypertension. Left heart caths are usually used to diagnose heart attacks, coronary artery patency. And then right heart caths can be left in for a CVP monitor, but left heart caths are always removed. How you feeling? Making sense? Questions?
I have a question.
Go for it.
How does it get through the valve? Because you're going against the normal way the valve opens.
Right, but it opens with every heartbeat, right? So you
Right,
just get in the middle of a heartbeat.
It's beating so quickly. I guess it's just hard for me to understand. I don't know.
So think about
they do it all the
going
time.
like this. You know, when you do this, we just kind of slip in, and you could just be pushing there until it goes in, kind of idea.
Okay.
Very good thinking, though. You're right, because we are going against the flow of blood. You do have to kind of force it in. But we're looking at fluoroscopy the whole time, so we can tell if we're forcing through a valve or if we're like forcing through the heart wall. We don't want to force through the heart wall. So that's why they're under fluoroscopy in the cath lab, that x-ray video the whole time. Good questions, Joe. Anybody else got any questions? Okay, let's take a break. It is 11:52. I'll start talking again at 12:02.
The stalls are clean.
I've got a love-and-hate relationship with LA. Off the plane, paint my face in the car, park my heart at the valet. I watch the sun sink down over Santa Monica Boulevard when I'm lonely and I'm missing home. But other times I feel like my blood is running Cali. I've got some famous friends that I could call, but I don't know if I'm cool enough. And what's worse than spending time alone is one of them not picking up. It's hard to grow and time to go, but some days I wanna stay. I got a love and hate relationship with LA. I wonder if I'll get invited to the party. I wonder if I'll get invited to the party. Yeah, and if I do, will I go? If I go, will I know somebody? I'm on my third glass of wine, trying to find conversation in a room with bigger names. But other days I'm looking up for real estate. Confetti's falling, friends are calling, saw me on the TV. But if I let down my hair in the ocean air, will Tennessee be mad at me? Yeah, I know it ain't a one-way road, but sometimes it feels that way. I got a love and hate relationship with LA. I got a love and hate relationship with LA. Sometimes it feels like it's all real, but nothing here is as it seems. I ask myself, does it feed my soul or my anxiety? Carpet's red, ego's fed, but it's myself that I have to face. I got a love and hate relationship with LA. I got a love and hate relationship with LA. Yeah, I got a love and hate relationship with LA. I got a love and hate relationship with LA. I got a love and hate relationship with LA. I got a love and hate relationship with LA.
My disposition permeates the room when I walk in a place. I'm sorry. By calculation, I'm way too much. Pretentiously, I bitch a bunch, but you bought it. I can't exceed my reputation. A small town girl with compensation, exploring all my possibilities. Well, don't you know I blaze a trail, but hell, you can come with me. What doesn't kill you only makes you blinder. My heels and my hotel, they just got chemically, as long as it contains some bleach. Well, I want it. You don't need to be a fighter, honey, just go one shade lighter. You'll acquire everything you want. When your roots grow out, things go south. Hey, go back to the salon. What doesn't kill you only makes you blonder. My heels and my hotels, they just got taller. Something about platinum, irrefutably. Looks as good on records as it does on me. Only makes you wonder. In fact, my heels and my hotel, they just got taller. Something about platinum, irrefutably. Looks as good on records as it does on me. Something about platinum, irrefutably. Looks as good on records as it does on me. The window is open, so's that door. I didn't know they did that anymore. Who knew we owned 8,000 salad plates? For years I've roamed these empty halls. Why have a ballroom with no balls? Finally they're opening up the gates. There'll be actual real live people. It'll be totally strange. But wow, am I so ready for this change? 'Cause for the first time in forever, there'll be music, there'll be light. For the first time in forever, I'll be dancing through the night. Don't know if I'm elated or gassy, but I'm somewhere in that zone. 'Cause for the first time in forever, I won't be alone. I can't wait to meet everyone. What if I meet the one? Tonight, imagine me gown and all, fetchingly draped against the wall. The picture of sophisticated grace. Ooh, I suddenly see him standing there, a beautiful stranger, tall and fair. I wanna stuff some chocolate in my face. But then we laugh and talk all evening, which is totally bizarre. Nothing like the life I've led so far. For the first time in forever, there'll be magic, there'll be fun. For the first time in forever, I could be noticed by someone. And I know it is totally crazy to dream I'd find romance. But for the first time in forever, at least I've got a chance. Don't let them in, don't let them see. Be the good girl you always have to be. Conceal, don't feel, put on a show. Make one wrong move and everyone will know. But it's only for today. It's only for today. It's agony to wait. Tell the guards to open up the gate. For the first time in forever,
Okay, come on back. Flip your cameras back on. So we're talking about cardiac catheterizations. Okay. We need to talk about bleeding prevention. The biggest side effect of these are bleeding, because when they're in there, they give the patient a lot of heparin IV. So I'm talking like 25,000 units of heparin IV sometimes. Okay, it's a lot of heparin. So we're really worried about them bleeding afterwards. So you need to understand that when the catheter goes in the skin, it's a little bit further closer to the heart when it goes into the artery, okay, or the vessel. So the needle goes in the skin here. You need to apply pressure about an inch closer to the heart, an inch proximal to the heart. So if the patient has the catheter here, you're going to apply pressure up here. The idea is if you put pressure right here, the vessel still bleeds and you get this big hematoma under the skin. But if you apply pressure here, you cut off pressure to the vessel so that it can clot. Okay. Does that make sense as to why we apply pressure an inch above? Because I don't care if the skin's bleeding. I care about the vessel underneath that's bleeding, right? And when you put in an IV or a catheter, you go in at an ankle like that. Okay. Okay. Other complications of cardiac catheterizations. Retroperitoneal bleeding. That's what you see right here. Retro means behind. Peritoneal is the cavity in your abdomen. So the place where your kidneys, your uterus, if you've got one, your bladder, your stomach, all that is in your peritoneal cavity. So behind your peritoneal cavity. If we do the femoral approach, once we, the femoral approach, they have to lie flat on their back for 6 hours after we do it. So if they're bleeding out of their femoral artery, let's say, it can actually leak into their back, causing this bruising on their flank. This is your flank area, okay? So this can happen with a right heart cath or a left heart cath, but it has to have been the femoral approach to cause it, retroperitoneal bleeding, okay? And when they're lying down, you may not think to look at their back for bruising, and their blood pressure will start to go down and their heart rate will start to go up until the heart rate goes down and their heart's about to stop because it just doesn't have any more blood left because it's all in their back. So this person can bleed to death without a drop of blood coming out of their body because all the arterial blood is now in their peritoneal cavity. Good on retroperitoneal bleeding? Okay. We can also cause a heart attack, myocardial ischemia, but it is only a left heart cath that can cause a heart attack. Why? A right heart cath is never going to cause a heart attack. Why does a left heart cath cause a heart attack? If you can answer this, I can tell that you understand left heart caths.
Is it because it's in the artery?
It is. It is because it's in the artery, because the coronary arteries are where heart attacks happen. A right heart cath never touches an artery, right? So that's exactly right. Good job, Eric. Thank you. We're also worried about bleeding, which we talked about. This is actually called a femostop. Okay, anybody ever seen these before? It's like an upside down Tupperware that applies pressure at the artery, and it's a belt that wraps around the butt cheeks, and then you pull it tight and blow this pressure up here with a sphygomanometer. It's like applying direct pressure to the femoral artery. It's really good, and these people will wear this for several hours after their cardiac catheterization so that we can get the artery to clot off, right, to stop bleeding. Okay. Both of the catheters, right and left, can cause dysrhythmias. The heart doesn't like to be touched. So when we thread a catheter in it, it's like, it's a little ticklish. So it does a little, so it can cause dysrhythmias, left or right heart caths, because the heart just doesn't want this, right? The right heart cath only can cause a venous spasm. Why can't a left heart cath cause a venous spasm? I saw Tracy mouth it. I saw Stephanie mouth. It's not in the vein, right? So it can't cause a venous spasm if it goes nowhere near the vein. But a right heart cath can cause the vein to kind of, the veins don't like being touched either. Sometimes they clamp down for a second or two, okay? Obviously, this is a huge infection risk because we're breaking the skin and going directly into the bloodstream. So we got to make sure they're sterile, that they're prepped before they go in. And then perforation is a possibility as well. Remember when Jill asked, well, how do you get it through the open valve? If you shove and it's not where it's supposed to be shoved in, you could go through the vessel or through the heart. Now, this catheter is like, it's literally like a flimsy little straw. It's like not even as stiff as a straw. It's very flimsy. So you'd have to shove it in pretty hard to get it through. But if they do that, I mean, that's always a possibility. But usually a perforation is going to happen when the patient's vessels are really, really weak to begin with, like very, very fragile vessels. Okay. So questions about those complications? Okay, let's talk about what we're going to do with these patients after they get out of cath lab. Okay, well, let's talk about before cath lab first. We are going to assess the patient for allergies. We don't want them to have an allergy to that contrast, like Dominique pointed out. We're also going to make sure they're NPO for 8 to 12 hours. Okay, because contrast causes an upset stomach, which will cause you to vomit, which will cause you to aspirate, which will cause aspiration pneumonia, which will lead to death. Worst case scenario, right? After the procedure, you're going to monitor for bleeding. Like I said, that's the most common side effect. So we'll have a femo stop, which is this thing right here. Or if they did a radial approach, we'll have what's called a TR band or a HEMA band. We don't need the 70s porn music. I'm going to just mute that. So this is a TR band. So you see they went in a radial approach. The catheter's still in there. They put on this clear bracelet. And they have this special syringe that blows air up into the bracelet. See how this is going to inflate? And as they apply pressure, it inflates and they pull out the catheter. So it's like you're putting pressure on. You're putting pressure on it, but you can see underneath your fingers. That's the idea of it being clear. Because if it keeps bleeding, they just blow more air into it. So you're applying just the right amount of pressure to stop the artery from bleeding. Okay. They keep this on for several hours after the procedure, usually at least 3. And then after 3 hours, you'll take out 2 mils of air. And then you'll watch, is it bleeding? Is it not bleeding? If it's bleeding, put the 2 mils back in. But if it's not bleeding, you wait 15 minutes, then you can take another 2 mils out, wait 15 minutes, another 2 mils, until you can take the bracelet off. It's kind of a slow way to make sure that they're not bleeding, right? Because a bandage, you can't see through a bandage. They could be bleeding underneath it. Okay. So that's a TR band. We're also going to monitor them for dysrhythmias. They're expected a little bit afterwards, but if they get aggressive and really, really bad, obviously we're going to have to deal with that. And we are going to talk about dysrhythmias in week 5 when we talk about extra EKGs. Okay. If they get the femoral approach, they have to be 6 hours on bed rest with a completely straight leg. The head of bed can only go 30 degrees up. How many of you guys could sit completely flat and still in bed for 6 hours flat on your back? No way, right? So you might need to give them some anti-anxiety or some pain meds if they're doing this. This is another reason we don't like the femoral approach, okay? The radial approach, they're going to be 2 hours on bed rest because we just kind of want to keep their blood pressure down. We're afraid if they're up and moving, the blood pressure will go up and then pop the claw off of the radial artery. They also need to, your Apple Watch would never allow what? Never allow you to get a radial.
Yeah, because it's always constantly be like, time to stand up. Time to stand
Oh,
up.
yes. Oh, I see what you're saying. Yes. It would never, you're right. It wouldn't. But you're getting the watch off while you do this procedure. So there's that. There's that. After 2 hours, they can get up. And then you can't sleep on that arm for a day. Because if you sleep on it, it increases the pressure and it could pop the clot off. So obviously, if you had to get one of these, I would vote the radial approach, right? Femoral approach is just a little bit too difficult. You're going to monitor for these patients for chest pain, especially if they got a left heart cath, right? Because left heart caths could cause heart attacks. And you're going to monitor their urine output. If they become anuric, which means no pee, or if they become oliguric, which means less than 30 mils an hour, we know their kidneys have taken a hit, which could mean they couldn't process that contrast. And if contrast stays in your body, that's bad. So we're going to have to run fluids and maybe even some Lasix to pull that urine out to clear through the contrast. Okay. How are you feeling about left versus right heart caths? Anybody got any questions about angiographies? Okay, let's see what you know. Let's try another polling question. This will be polling question number 5. There are 2. There are 2 questions on here. I can see you guys thinking through that. That's how we want you to do. That's how we want you to do it. Just memorizing it isn't as good as thinking through it. So I'm glad you're thinking through it. Okay, let's do another 10 seconds.
So, Professor Solis, if they do go into through the femur, why would that femoral? Why would they do that as opposed to the radial? Because
Very
you made
good
it seem
question.
like they don't really do that one, you know?
Right. It's our second choice. And that kind of goes along with what Macy put in the chat as well. We would do radial, but if it can't be done, like if they don't have good enough blood supply, because when you do a radial approach, you're cutting off radial artery supply. So unless your ulnar artery can supply your hand, we're not going to do that. So they test it first. They occlude both arteries and then they open up the ulnar. And if your hand turns pink again, they will do radial. But if your hand doesn't pink up, then you fail. I think it's called the Allen test. Could be the Wright's test. They do that, and then they'll try your other arm. And if that doesn't work, then they'll go their femoral. So what Macy said is they try to go radial first because that's always our first choice if we can. But some people you just can't. And that's, I would say maybe 1 out of 5, they'll do femoral instead. So it's pretty common to have to go femoral instead. Good questions.
Well, because my aunt had one done like a couple years ago and they did do a radial one, but just recently she needed another one and they didn't even go through there at all. They just went straight to the other one. I'm
guessing they tried, like they checked while they were in cath lab, they did the test and she just didn't have very good blood flow. Because if you don't have very good blood flow, we're not going to occlude an artery, right? We'll go through the femoral artery because it's bigger. Yeah, good questions, Carla. Okay, so let's look at these questions. Which complication is only possible in a right heart cath? The answer is venous spasm. A myocardial ischemia is the answer for number 2. What's possible in a left heart cath? And both left and right have perforation and bleeding risks. Now, the reason the answer is venous spasm for right heart cath is because right heart cath is the only one in a vein. The reason the answer is myocardial ischemia for left heart cath, the left heart cath is the only one that goes anywhere near where you can have a heart attack. Because a heart attack always happens in the coronary arteries. Questions? Okay. So let's talk about our last diagnostic test. This is the electrophysiology study, also called an EPS study. It's done in a special EP cath lab. What they do is they go in like an angiography, so it's invasive, but they have better technology than the cath lab. The cath lab is working with black and white fluoroscopy. These guys have a full color. They can test electricity. They can test blood flow. It's awesome. They don't have EP cath labs in hospitals. This is like a special outpatient facility. Okay. And so it's an invasive and they can actually go in and they can say, you know what? What's causing your dysrhythmia? Usually it's like AFib or SVT. It's that heart muscle cell right here. They can narrow it down to one area. That's how precise they can get. And when they see it, they're like, you're the reason he's got AFib. They kill it. They can do an ablation where they burn the heart muscle dead because it's overactive, so they kill it so you don't have AFib. Or they can do a maze procedure where they kind of take a core sample and they scoop it out and it creates a maze in the heart. That's why it's called a maze procedure. Okay. So an EPS cath lab can cure some AFibs and SVTs. Okay. And it can discover exactly which heart cell is causing the dysrhythmias. Questions on any of the diagnostic studies? Okay. Now we're going to move on to coronary vascular disorders. These are problems in your coronary arteries. Okay. So we're going to talk about coronary atherosclerosis. We'll talk about angina pectoris. Now, it's pronounced two ways, angina or angina. Either way is correct. I find myself going back and forth. I don't have one that I prefer, but I know that angina sounds like vagina. I know that. Everybody knows that, okay? So if it makes you giggle a little bit, giggle inside your heart, okay? Because I'm either going to say angina or angina, but it's both the same. We're also going to talk with angina. It's stable angina, okay? Then we'll talk about acute coronary syndrome. Acute coronary syndrome includes unstable angina, which will differentiate between these two in just a sec, but it also includes a heart attack. Myocardial infarction, also called an MI, also called a heart attack. Now, do you know a myocardial infarction is not a cardiac arrest? Do you guys know that? TV makes you think like both of them are the same thing. They are not. Okay. Myocardial infarction, a heart attack, is when part of your heart muscle dies. The rest of your heart is fine. The rest of your heart is working. A cardiac arrest is when your heart stops. So if you have a big enough heart attack, just like Brianna was asking, if it's a big heart attack, do you get more symptoms? If it's a big enough heart attack, it can cause a cardiac arrest. But most heart attacks do not cause cardiac arrest. Okay, so myocardial infarction is a heart attack, part of the heart muscle dies. Cardiac arrest is your entire heart stops beating for some reason. Good on those two? Okay, so this is a picture of your coronary arteries. I've labeled them here for you, but I don't expect you to memorize these. Okay, I just expect when the doctor says that the patient has a STEMI in their LCA, that you know that means left main coronary artery. Like you'll recognize LCA, LAD. LAD is the most commonly occluded one. It's actually called the widowmaker because it kills. It kills people. Okay. And so these are the arteries, but again, I don't expect you to memorize them. Okay. Just know that these are the arteries, and if there's a clot or an issue here, all the tissue that's supplied by the vessel downstream starves. Okay. How are you feeling? Okay.
Vessels that they say it's a triple, I think it's a triple A when they can't put a stent in the heart. So
a triple A is an abdominal aortic aneurysm.
Sorry, not a triple A, then it's something else. I just heard about it, but I can't remember what it's called. But
okay,
if these, I'll come back. I'll figure
okay,
it out.
No worries. There are some of these that you can't get stents put in, and so when you can't get stents, you get a bypass, a cabbage. And we do say like cabbage times 1, cabbage times 2, cabbage times 3, cabbage times 4. That means how many arteries are occluded. How many arteries do we have to bypass? And we'll talk about that in just a sec. So I'm thinking that's maybe where you're going, is cabbage, CABG. Okay, yeah, we'll talk about that in just a sec. Okay, so coronary atherosclerosis. This is a type of coronary artery disease. It's like normal atherosclerosis, except it's in your coronary artery. That's the only difference, okay? 3 vessel disease. Oh, I don't know about that one, Dominique. Let me look into that one. 3 vessel disease. Okay. So coronary atherosclerosis, what happens is you're going to get symptoms like angina pectoris, chest pain. You could get a heart attack with this, and you could get a cardiac arrest. Your heart could stop. You're also going to have high cholesterol. Hyperlipidemia is one way to say it, but hypercholesteremia is also another way to say it. Medicine is really confusing. We give one name to like 3 things and then 3 names to one thing. I don't know. But with hypercholesteremia, you have high bad cholesterol and low good cholesterol. Now, I have given you the pathophysiology of a coronary atherosclerosis. I am never going to test you on patho. You've been tested on patho. But let me tell you, knowing the patho is going to help you know the symptoms. And I am going to test you on symptoms. Okay. So what happens with coronary atherosclerosis? You have a vessel. And so we've taken a vessel. We're looking down it like a straw, and then we cut the top off. So now we just see this U part. Okay. It's what a nice, healthy vessel looks like. We get some sort of injury inside the vessel. And 9 times out of 10, this injury is caused by hypertension, because high blood pressure shoots at that vessel and causes a rip in this fragile endothelium. So we get a little rip, and then your body comes to heal it because it's a healthy body. So it's going to do that. And it attracts these inflammatory cells. The inflammatory cells ingest lipids and they deposit on the wall. And then you get these fat buildup, and it's called a atheroma or a plaque. So now instead of having a nice patent coronary artery, you have a plaque that's occluding like this much of it, right? So it's taking up space, causing hypertension in those coronary arteries, okay? So your risk factors for coronary artery disease are all the same risk factors for every other heart issue. Do any of these surprise you that they can affect your heart health? Right? But we can advise the patients on adjustable or modifiable risk factors. So is smoking a modifiable risk factor? Yes? No? Absolutely it is. It's hard to stop smoking, but it's doable. What about diabetes? Is diabetes a modifiable risk factor? It depends on the type. Type 1, not modifiable. Type 2, absolutely modifiable. So I'm never going to ask you a question like that on a test. That's too confusing. But type 2, you can actually cure if you diet, exercise, and meds. Type 1 is never going away. Okay. How about family history? Modifiable? Non-modifiable. Non-modifiable. No matter how much you want to, you cannot change who your family members are. We know that, right? Okay. Patient education for this. They need to recognize the signs and symptoms of a heart attack, because it's not if they're going to have a heart attack, it's when are you going to have a heart attack? Okay. If you have coronary artery disease, you are definitely going to have a heart attack unless you completely change your life. But for some reason, diet and exercise are the hardest prescriptions to get people to fill. And you guys, I'm sure, are the same way, right? I would rather take a magic pill than go to the gym. I would rather take a magic pill than change my diet, right? And so that's really, really hard. So people with coronary artery disease rarely change their life. So they end up having heart attacks. Okay. I like this little cartoon here. This kind of reminds you your patient education. This isn't a real thing, but it's this sensor that they put on his chest. Whenever your cholesterol gets too high, a sensor will send out a signal that automatically locks the kitchen door and turns on the treadmill. Because you got to do diet and exercise when you got coronary artery disease. Okay. Okay. How you feeling about coronary artery disease?
I have a question.
Go for it.
So if they go on medication and they have really bad atherosclerosis, does it ever go away? Or is it like if they are on the medication, is there any way to get it out of their arteries without going on medication?
If they do diet and exercise, usually they can, like, they'll be on medicine for a little while and then they can get off the medicine if they do enough diet and exercise. For most people, there are some people who have familial hyperlipidemia, meaning you're genetically predisposed to have way more fat than anybody else. So unless they go like to a completely like a keto diet where their body only eats fats, they're going to be on meds their whole life. Does that answer your question, Liz? Okay. It's pretty unlikely that they're ever going to get off meds in real life. In theory, yeah, it's a possibility, but likely not very, because nobody likes to diet and exercise. Good question. Any other questions? Okay. Next one is angina pectoris. This is episodes of pain or pressure in the anterior chest. So this is chest pain. It is caused by atherosclerosis. Okay. The clinical manifestation is chest pain, but it could be something like, it feels like indigestion. Like it's like, do I have chest pain or do I not? I can't really tell. Or it could be so bad they're like, I can't breathe. They can't breathe because it hurts so bad. Okay. And again, that goes back to what Brianne was referencing. How bad is it? Right? However bad your heart attack is, that's how bad your symptoms are. So each person gets a little bit of a different set of symptoms. To assess chest pain, we're going to assume it's a heart attack. So we're going to do a 12-lead EKG. We'll take their history, asking them all those cardiovascular risk factors. We'll do labs looking specifically for troponin, because if they've got troponin in their blood, we know it's a heart attack, right? We can do a stress test if we don't see anything on the EKG or anything in the labs. We could do a nuclear scan if we don't see anything on the stress test. And we could do a left heart cath, a cardiac catheterization, to see if they do have an occlusion of their coronary arteries. So stable angina is predictable. So something like every time I walk up 7 steps, I get chest pain. Okay, it's predictable. And it's consistent, but if you sit down and rest and take nitro, it goes away. That's how you know it's stable angina. Okay, every time I walk up 7 steps, I get chest pain. That's stable angina. Unstable angina, the symptoms get worse and worse. So it might feel like indigestion once, but then it feels like you're choking eventually, right? It gets worse and worse. And it could just happen. You don't even have to be doing something exerting. It could be you're sitting watching TV and it starts to happen. So unstable angina is obviously more severe than stable angina. Okay. Good on those? So now let's take a look. I love this infographic. I feel like this really paints a good picture as to what's happening in the heart. So coronary artery disease is when the plaque builds up, but the blood is still able to get through. Angina, either stable or unstable, there's so much plaque that the blood has a harder time getting through. So all the stuff downstream, sometimes it goes without oxygen for a second. So that's what causes that chest pain. Because remember, your heart can't speak English and say, excuse me, I need more blood. It says, ow, 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 right? So that's stable and unstable angina. A heart attack, a myocardial infarction, is when it's so occluded by plaque and the tiniest little clot comes around. Do you guys know that you have clots in your body all the time? Just teeny little ones, not a big deal. It's when you have atherosclerosis, one of those teeny ones gets stuck and now literally no blood is happening down here. That is a heart attack. And your body is screaming out in pain because it needs blood and oxygen to live. And if you don't give it blood and oxygen for long enough, it's going to die. And that's myocardial ischemia. Okay. Does that help kind of show you the steps? Right? First, this is the most mild coronary artery disease, but then it becomes some sort of angina, either stable or unstable, usually stable, then unstable, and then a heart attack. Okay. So acute coronary syndrome. The heart's not getting the oxygen it needs. Lots of different symptoms. We're going to watch this video. Do you guys recognize her, Elizabeth Banks? She's an actress. She's a young person. I think she's like maybe in her late 30s, early 40s. She had a heart attack. We're going to watch this video and she acts out the symptoms. And I'm hoping this video will help you remember the symptoms of a heart attack, because it's not all just grab your chest and fall over like it shows in the video, in the movies. Okay. So give me just one sec. Okay.
It started out like a totally normal day. Mom! Okay, move objection deadline to the 3rd line after survey. Oh, honey, for when you always use the verb at start. What are you doing down there? Did you finish your breakfast? Ow. Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly. Spaghetti. You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her shoes. Nobody move. I'm getting a dustpan.
Oh. Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
Okay. Love that video, by the way. I never get sick of watching it. Why do you think Elizabeth Banks had a heart attack? Any ideas?
Stress.
Yeah, stress. Now, how many of you looked at her morning and was like, yeah, that seems right. That's what my morning looks like, right? When you get kids to get off to school, it's just complete chaos, right? So this is hopefully to help nail home that mental health causes physical issues and that stress can make cardiac events manifest in a different way. She didn't just grab her chest and fall over, right? Anybody else notice anything you want to talk about in that video?
Why didn't her kid call 911?
Because her kid is more intuitive than her husband was, apparently, right? Are you okay? Hint, gentlemen, when women say we're okay, we're usually not okay. Okay. Right? The kid was more intuitive. The kid realized, hey, this is an issue. Right?
He didn't call. He just handed her the phone. It was like, here.
Mrs. Honor Dog was not going to wait. She's got to go to school, right? Okay. I love that video.
I also thought it was funny how despite the fact that she has a heart attack, she's like looking at her house like that's still a priority in women's head. That's crazy, right?
It is. It's totally. We would rather present this good facade, get our kids taken care of, our husbands taken care of, right? That's a woman thing. Women are totally like that. You're right. And so women are more likely to ignore heart attacks. We're less likely to have them, but we're more likely to ignore them. It's a really good pointing that out.
She kept clutching her, or not clutching, but on her left arm, she just kept
moving it, right? Feels like stiff or achy kind of thing, right? And that's not a normal thing where you would like, oh, they've got a stiff arm, they keep moving it. Like, is that a heart attack symptom? Yeah, it could be, right? Good point, Eric. Thank you, guys. Okay, so assessing a heart attack. We're going to take a patient history. When did it start? What are your cardiovascular risk factors? We want to know definitely if someone close to you died of a heart attack, someone related to you by blood. But do you think it matters if my grandfather was 97 and he had a heart attack and died? Do you think that's part of my history? It's not going to be really helpful. But if my dad was 33 and had a heart attack and died, yeah, that's really important to know, right? Let's see, we'll do a 12 lead EKG. A 12 lead EKG, if you're having a heart attack, will have one of these, possibly. Inverted T waves. T waves are supposed to be mountains. If they're valleys, could mean they're having a heart attack. And we'll point this out again when we get to the EKG lecture. ST segment depression or elevation, okay? The ST segment is supposed to be along the baseline. If it's too high or too low, could mean a heart attack. And hypertrophic T waves. If your T wave is huge, like bigger than your QRS, That could also mean you're having a heart attack, okay? We'll do a chest x-ray. A chest x-ray is really just to rule out what it's not. A chest x-ray can rule out heart failure, myocarditis, pneumonia, pneumothorax, because all of those cause chest pain too, right? So it can help rule out some things. And then our labs, we're going to do troponin. And then this is the same little graphic that I put on the first slide about troponin. Just reiterating, it doesn't show up for 2 to 3 hours. Okay. Okay. So what are we going to do to take care of a heart attack? Well, first of all, you need to know the difference between ischemia and infarction. Okay. Ischemia is lack of blood flow. So I'm holding my wrist tight and now my hand is getting mildly ischemic. I'm not going to cause an infarction in my hand because I cannot hold it for days and days, right? And well, maybe not even that long, for hours. It takes a while to not have blood flow before your tissue starts to die. So this is lack of blood flow. This is tissue dying, okay? So myocardial infarction is when your heart muscle, parts of your heart muscle are dying, okay? To manage this, we're going to try and minimize heart damage and preserve heart function. And the way we do that is to work as quickly as possible. Time is heart. The longer you have a heart attack without being treated, the more possible damage that could occur, the more heart muscle could die, okay? We're going to try and prevent complications because after a heart attack, it can lead to other things, okay? Your heart is weak, you're immunocompromised. So this is how we're going to treat our patients. And this is a really good prioritization idea, okay? To prioritize what you're going to do. First things first, the patient needs to use rapid transit to the hospital. This is ambulance. Even if they live across the street from the hospital, I want them to call 911 and get an ambulance. Why do you think it's important to do rapid transit? Any ideas?
Because they have more resources on an ambulance. You wouldn't want to take them in your car and have something fatal happen.
Exactly right. Plus, if you live across the street, when you're walking across the street, that's you're increasing your oxygen demand in your heart, causing more problems, right? So both of those things, very good. The EMTs can get a 12-lead echo or 12-lead EKG within the first 10 minutes, and they can actually fax the EKG or send the EKG to the cardiologist at the hospital. So the hospital cardiologist will read this EKG in 10 minutes. Okay. Once they get to the hospital, we're gonna draw blood. We're looking for cardiac biomarkers like troponin. Obviously, if it didn't start 2 or 3 hours ago, we're not gonna see it yet, but we will keep drawing troponin until we see something. Then we're going to obtain any other diagnostics to clarify the diagnosis. That's where we're going to throw in like a chest x-ray to see what it's not, maybe talk to them about asthma or pleuritic pain, right? Trying to figure out what it's not. Once we've decided it's a heart attack, then we do routine medical interventions. Were you guys taught Mona for heart attacks? Some of you, yes, okay. Mona is dead. We don't do Mona for heart attacks anymore. No more Mona, okay? Get Mona right out of your head, okay? So usually it was oxygen first, but we are not going to give oxygen unless the patient's hypoxic. So if their SATs are above 90, don't give them oxygen. There was a huge study. It was done on 25,000 heart attack patients in Japan. And they showed if you gave them oxygen when they were not hypoxic, it actually increased the risk of death. So no oxygen unless they're hypoxic. Our next thing would be nitro, right, for chest pain. Nitro, we're only giving if it's not a right inferior wall infarct, which your cardiologist that reads the EKG can tell you. I'm not even going to pretend to be able to know how to do that, okay? But if it's a right inferior wall infarct, you don't want to give nitro because it'll actually make it worse, okay? Morphine, we're not giving morphine at all anymore for heart attacks. They've actually correlated that if the nurse is wasting time giving morphine, it's delaying their antiplatelet medication. So it's delaying, it's causing more time buildup when they could be getting TPA or going to the cath lab to get it fixed. So no morphine. Plus, morphine covers up your symptoms. I want you to be able to tell me if your symptoms suddenly go away. That's an important clinical finding, right? So no morphine at all.
Okay,
Aspirin,
so sorry.
go ahead. No,
in
you're fine.
in SCE yesterday, we did all of those things. We gave them oxygen.
Was he hypoxic?
No.
Who is your SCE instructor?
They told us as long that we wanted to keep, it was better to give him oxygen than to, I can't remember the way she said it. Am I the only one that was like that?
No, I think they told us to administer oxygen if they fell below 90.
No, ours was if it fell below 93.
Okay, 93, sure. I'll give you 93.
But she said to always put it on. That should be one of the first things that you do, because then they're going to start losing oxygen or something. But she acted like you, it was like, I can even get my format. It was one of the first things written on there was put oxygen.
Liz, will you email me her name? And
Yeah.
I will talk to her about that, because this is a recent change. This is like within the last 3 years, they've decided this isn't okay anymore. So I will email and talk to that person and give them all the evidence-based practice they need to recognize that that's not what we're doing anymore.
Okay.
So thank you for bringing that up. Yeah, just let me know who it is. We'll talk to it. So to that point, I hypoxic. Ideally, if they're below 90, give it. I would say 93. Some people get really nervous if they're in the low 90s. I'm an ICU nurse, so I don't. I get nervous when they're below 90, but so only if hypoxic for that. Nitro should only be given if it's confirmed that it's not a right inferior wall infarct, or if we know if it's stable angina, you can give nitro. But if it's a heart attack, we are not giving nitro if it's a right inferior wall infarct. That will actually cause more damage than good. Okay, and then morphine should not be there at all. At all. No reason to give morphine anymore.
Sorry, I have another question.
You're fine.
So when they come in like through the emergency and you give, like, they think they're having a heart attack, you don't just give them nitro.
Nope, not anymore. We have to do a 12 lead first. Good clarification. But we can give them aspirin. Is the only part of Mona that's still alive. Everyone who's having a heart attack, or we think is having a heart attack, they can have some aspirin to chew. But we're not doing any of these stuff. These two only if they meet the requirements, and morphine not at all anymore. Even, you guys, I got this chart from your book. I had to add in this extra stuff because this is so new. And your book is only from like, I think 2018, 2019 or something. So this is a new development. So I'm not surprised in the slightest that you guys are still being taught MODA for things, okay? Okay, we could do aspirin. We could throw in some beta blockers. Beta blockers are really good for heart attacks. We could do some ACEs. At least we'll start an ACE in the first 36 hours. We'll do anticoagulation or heparin or platelet inhibitors to decrease their chance of clots. And then we'll give them a statin before they go home. Okay. These people also have to go to cardiac rehab. It's like pulmonary rehab, but for cardiac patients. So they go and exercise with a doctor and nurse present so that we can make sure they're exercising enough, but not too much. And it takes time. That's part of the education, is it's going to take time to get back to normal. Do you think Elizabeth Banks could do everything she did the day before her heart attack, the day after her heart attack? No, it takes time to build up that resistance to get back to where you were. Okay. Questions? Okay, let's do another poll question. This will be poll questions, the 6th one I've given you. Okay, let's do 10 more seconds. Okay, so this is what we were just talking about. This is a really important topic, so I want to make sure we get this right. Which aspect of MONA still automatically applies to a patient with chest pain? Aspirin. We're not giving oxygen unless they're hypoxic, and we're not giving nitro until we have decided and figured out that they're not having a right inferior wall heart attack. Okay, so aspirin is our answer there. And I will definitely talk to Sim. Any other, oh, go ahead, Liz.
Yeah, I just pulled my paper out and she did say something about oxygen below 90, but she said that it's better to be safe than sorry. And then she also said that you give aspirin, nitro, and morphine. And it's all listed right here on my paper. And we did it in SCE, so.
Okay, I will definitely talk to her. Just send me the person's name and I'll talk to her for sure. Because that used to be what we were. That used to be what we were doing 2-3 years ago. But now, no. We've changed. Okay.
Professor Sollis?
Yeah, go ahead, Eric.
So the morphine, was that primarily before for the pain, right? But
Yes,
now
it was to cover up the pain.
Right, and so the aspirin's doing double duty then?
Aspirin for pain is like
the pain and
this much. Yeah, it's doing much more for antiplatelet. We're trying to thin the blood. Yeah. Aspirin doesn't do a ton for pain, especially in this kind of scenario.
Okay.
But, yeah.
Right,
good question. Okay, so now let's talk about the drugs that we use during heart attacks. Okay. Beta blockers, like I said, are really, really good for heart attacks. Our biggest one that we use in the hospital is metoprolol. Okay, remember anything that ends in olol is a beta blocker. What it's going to do is it's going to pull it out of a different rhythm. So if it started going and panicking into a dysrhythmia, it'll help with that. It also decreases blood pressure, and it also grabs those dead heart cells back from the brink. They're almost dead, and it reinvigorates them. So beta blockers are really good for heart attack patients. Vasodilators, if they're not having a right inferior wall infarct, we can give that nitro. Okay. Antiplatelets, like I said, aspirin's okay for everybody. We can also give clopidogrel, which is another antiplatelet if we wanted to. It's a little stronger than aspirin is. And then we can give anticoagulants to prevent the blood clot forming and getting larger, right? So that would be heparin, enoxaparin, or glycoprotein 2,3 inhibitors. Okay. All of these can be given before, during, and slightly after a heart attack to try and help thin that blood out, to try and not get so many clots stuck in that tiny little stenotic area. Okay. Now, nitro, definitely take a look at nitro patient education. There is a select all that apply question on the test for this. Okay. You need to know how to tell your patient because they are taking a very strong cardiac med at home alone. You need to tell them everything you know about it so they can take it safely. Okay. And we will prescribe this for stable angina. Okay. They're going to take a pill while they're sitting and stopping all activity. Remember, I gave you that example. If I walk up 7 steps, then I get chest pain. Well, don't keep walking up the steps. Sit down, right? Then take your pill. They're going to take 1 pill when they have chest pain, and then they're going to watch the clock. If they still have chest pain in 5 minutes, they're going to call 911 while they take pill number 2. And if they are not here by 5 more minutes, which would be 10 minutes after the chest pain started, then they can take pill number 3. Okay. But if the pain isn't relieved with 1 pill, they have to call 911. Okay. They can also
Professor Sollis?
Yeah.
When would a doctor prescribe the nitro? Like, is it after, like, let's say I have a heart attack and I go in and they do studies, whatever, and I don't necessarily have a block, but just because of stress, I got a heart attack. Would they give me that nitro just in case it ever happens again?
They probably would, because before you ever have a heart attack, you have stable and then unstable chest pain. You have stable and unstable angina first. But most people kind of ignore it. They're like, oh, I just got heartburn or something. It's something little that they kind of ignore. So absolutely, they would prescribe nitro after a heart attack. Yeah. Good question, Carla. Okay. So then they can also take the nitro PRN for chest pain. Well, I know every time I walk up 7 steps, I get chest pain. So I'll just take a pill before I walk up the 7 steps. They can do that. But they can only do it once every 12 hours. If they take it prophylactically before they actually need it, more often than every 12 hours, they build up a tolerance and now nitro won't work for them. Okay. Remember, erectile dysfunction meds are contraindicated. If they are taking something like Viagra or Cialis, and then we give them nitro, all the blood in their body is going to be in their genitals, not in their brain, which is not good. Now, notice that I said genitals and not just penis. Do you know that women take ED medication as well? ED medication was actually initially meant as an antihypertensive for pulmonary artery hypertension. So some women with pulmonary hypertension take things like Cialis because it's a really good vasodilator. So if we throw in one vasodilator and then add nitro on that's a vasodilator, you bring their blood pressure so low they could die. So you got to make sure you don't do both of those drugs at once. Okay. We're going to store our nitro in a dark, dry place like a sock drawer. Okay. Side effects that they're going to see are headaches. You always get a headache after nitro because it vasodilates so fast that it's like a blood rush to your head. You know, like when you hang upside down when you were a kid. Now when you try it as an adult, it gives you a headache. That's essentially what's happening. It's just a blood rush to your head. And their blood pressure is going to go way down. Okay. Now, types of nitro, we can do the sublingual tablets. That's what these are. You guys, this bottle in real life is like this big, like an inch tall. It's got 20 pills in it. These pills are freaking microscopic. Okay. So when a patient needs one, don't just hand it to them. They will drop it. They're having a heart attack. Okay. They will drop it. They're having angina. They're stressed out. Take it, put a glove on, take it, and put it directly under their tongue. Otherwise, it's going to get lost in the sheets and you'll have to go find another one. Take it from somebody who's lost them many times because they're very, very teeny. Okay. We can also do ointments. It's like this thick paste and we put it above their chest and then we put a tegaderm on it. Okay. We can do that. I've seen that a few times. We can also do patches, nitro patches. They put them on in the morning and then take them off at night. So they put them on while they're active and then they take them off at night. Or nitro sprays. They're sublingual sprays under the tongue. Okay. Whatever they have, they're going to have to replace their stock every 6 months because after 6 months, no matter if they used it or not, it's expired. So you need to replace this stockpile pretty often. Questions on nitro patient education. Okay, let's talk about ways to fix a heart attack. We can do thrombolytic therapy, which is TPA. We can do an invasive coronary artery procedure called a PCI, percutaneous coronary intervention. It's like a left heart cath, but instead of just looking around in the coronary arteries, we balloon it open. That's what PTCA is, percutaneous transluminal coronary intervention, angioplasty. And we put a stent in. Okay, so this is stent placement. All they do is they get a little tiny hole like the size of an IV. Okay, but if they can't do that, like when Dominique was talking about, well, what if they can't put in a stent? I'm still not sure about three vessel disease, but there are some people whose arteries are so occluded we can't even get the catheter in to blow the balloon up. Those people get coronary artery bypass graft surgery. CABG is what we call them, CABG. Okay, so first way to fix a heart attack: thrombolytics, clot busters, TPA, alteplase. All of those are all the same name. They're all the same drug. Okay, we can do it systemically, meaning we just give it to them in an IV. But you need a lot more if you're going to anticoagulate the whole body, right? But they can also do it targeted. If you go into the cath lab with a left heart cath, you can actually squirt TPA right on a clot. You need a lot less TPA and it works a lot faster. Okay. There are some contraindications to TPA, which are here. Most of them involve not letting your patient bleed to death, which is a good idea, right? Okay. If they're bleeding already, now remember, active bleeding could be things like a woman on her menstrual cycle. That's active bleeding. We're not going to give someone on their period TPA. If they have a known bleeding disorder like hemophilia, stay away from them with TPA. Okay. History of hemorrhagic stroke ever in their life, they don't get TPA because TPA has a risk of causing hemorrhagic stroke. Okay. Any of these things, pregnancy, stuff like that. Okay. So take a look here and just know when not to give TPA, because the biggest nursing consideration is that they're going to bleed. Okay. And this is TPA. So TPA comes in this vial and it comes with some sterile water. It gives you a double spike and you put both bottles together. So you have like a bottle here and a bottle here, and you're flipping them over and over to mix them together. And then they're glass bottles. This actually becomes your IV bag, this glass bottle. And when you use a glass bottle on an IV bag, you have to open the valve. See this little blue door here? You can't squeeze the bag to prime the tubing, so you have to open the valve so that the pressurized can suck the fluid out of the glass tube. So whenever you give glass medications, which there are a few, you're going to have to open that valve. Okay. Questions about TPA? TPA is given in rural settings a lot when they don't have a cardiothoracic surgeon to do a left heart cath. But here in Salt Lake Valley, we have a lot of cath labs. Like every hospital has a cath lab almost. So in cath labs, that's when we'll do the PCI, percutaneous coronary intervention. It's like a left heart cath with a balloon and a stent. Okay, we go in an artery. Hopefully we're doing a radial approach, just like a left heart cath, okay? Now the reasons to do PCI, either we're doing it because we think they're about to have a heart attack, like they have a lot of symptoms of coronary artery disease. And we go in with a left heart cath and we see, oh my gosh, their vessel is 90% occluded. We got to get that in there before he has a heart attack. And then they can open it up. A left heart cath can turn into a PCI. Okay. We also do it during a STEMI, ST elevated myocardial infarction. We're doing it while they're having a heart attack. We actually go in and open up that artery so that all the blood can start passing through again. Okay. And it's an alternative to the CABG because a CABG is an open heart surgery. This is just a tiny hole in your vessel that you can't even fill, right? This is just a tiny hole, not a full open heart surgery. So there's two parts to PCI. We got the balloon part and the stent part. The balloon part is called percutaneous transluminal coronary angioplasty, PTCA. And the stent part is just called the stent. Okay. The stent is like a tiny chain link fence cylinder. Okay. And it goes in and it kind of props the artery open so it can't close up again. This video that I showed you on left heart cath is a left heart cath that turns into a PCI. So this video will walk you through those ones if you want to take a look at that. Okay. Complications of PCI. Pretty much all the exact same complications that we had with left heart cath. Nothing really different here. Okay. The nursing considerations for PCI, I literally cut and pasted the nursing considerations from left and right heart cath. It's the exact same thing. All I did was put a picture of a femostop here instead of the video with the TR band. Okay, we treat it all the same. Femoral approach, 6 hours of bed rest. Radial approach, 2 hours. Watching for infection, watching for dysrhythmias, all the same thing. Because the body or the patient doesn't know it any different. Okay. If someone went and got an angiography and your cath lab didn't like call down and tell you what happened, you wouldn't know if it's a left heart cath, a right heart cath, or a PCI. They look all the same from the outside. Okay. Questions about PCI? Okay. So traditional and alternative CABGs. So what a CABG is, it's a coronary artery bypass graft. So what happens is you see these guys have some clots right here. So the blood isn't getting to this part of the heart. So we take another vessel from the body. In this case, they're using the saphenous vein. And they bypass these clotted parts. So now we're feeding aortic blood down into this bottom part of the heart to bypass the clots. Okay. Same with this. This person, it has a CABG times 2 because there's one and there's another bypass right here. They have a clot here, which means everything down here is not getting blood. So they got, this one is the mammary artery that they pulled and they hooked it to part of one of the branches down to feed the rest of the heart muscle. Okay. This is a second choice. We do not want to do this if TPA or PCI works. We don't want to do this because this one, you are actually going to the OR. They are going to cut open your ribs, pry your heart out of your body and then sew it, right? We don't want to do that if we don't have to. These people get anesthesia. Now, what makes this traditional versus this one, which we'll talk about, is alternative. Traditional CABG does cardiopulmonary bypass machine. So this surgery uses this special machine. It sucks all the blood out of your heart and lungs, and it pumps the blood through your body. Even though your heart is stopped for surgery, you're still alive because you have the bypass machine. This machine is pumping and heating and filtering your blood through your body. But the doctor doesn't have any blood to work with. This is a lot easier on the doctor because the heart is stopped and there's no blood. Imagine trying to sew, right? But you're sewing something that's bouncing and it's covered in blood, right? It's a lot harder. Okay. So this one is easier on the doctor, but much more difficult on the patient because there's lots of complications of bypass machines, not the least of which doing, let's just hope your heart is strong enough to restart an hour later, right? Plus they throw clots with bypass, they can hemorrhage, they get dysrhythmias, they have heart attacks. We would rather not do a bypass machine during bypass surgery. What we would like to do is an alternative bypass, okay? The alternative ones do not stop the heart. They use beta blockers to slow the heart down so it's bouncing a little bit less. And they use this thing right here. It kind of suction cups to the heart. It's called a myocardial stabilization device. They're trying to hold the heart still so the doctor can sew. Now, obviously, there's still blood in here. The heart is still beating. So this is harder for the doctor, but it's much better on the patient because we didn't stop their heart. Okay. So alternative CABG, no cardiopulmonary bypass. Traditional CABG, cardiopulmonary bypass. This one is for like, if you have six clots, this one is what you're getting. If you only have one clot, maybe you'll get this one. And all of this is done after we've realized PCI isn't going to work for this patient. Okay. Questions about CABGs or heart attacks? Okay, got another poll for you here. Poll question number 7, try that one. Okay, let's do 10 more seconds. Okay, everybody answered. So what's the difference between a traditional CABG and an alternative CABG? A. Traditional CABG uses cardiopulmonary bypass. Alternative does not. So B is backwards, and C and D are also backwards because an alternative CABG is easier for the patient, but harder for the surgeon. A traditional CABG is easier for the surgeon, but harder for the patient. Questions? Okay, so we've got about 15 more minutes. I have put in a few more poll questions if we want to do that, or we can go over students' questions. Anybody have any preference? I think we only have time for one or the other. Anybody have any preference?
Poll questions.
Poll questions? Okay, I see poll there. Okay, let's do poll questions then. So these questions are written more like what you'll see on the test, okay? So try that one right there, and then we'll talk it through. This one's a select all that apply. Okay, let's do 10 more seconds. Oh, everybody got it. Okay. So the student nurse is preparing a teaching plan for a client being discharged status post-MI. That means they just had a heart attack. What should the student include in the teaching plan? What are we going to teach this patient about? Select all that apply. We are definitely going to teach them about the need to carefully monitor cardiac symptoms. Because if you had one heart attack, chances are you're going to have another one. Okay, so A is right. B, need for carefully regulated exercise. Yes, we don't want you to go crazy on the exercise because you got scared of a heart attack because you're not ready for that yet. We got to get you healthy enough first, so you're going to need cardiac rehab. So B is right as well. C, need for dietary modifications. Absolutely, right? If you have a heart attack, you need to change the way you eat because that's why you had it. Okay, so C is correct. D, early resumption of pre-diagnosis activity. No, we don't want them like running a marathon right after they have a heart attack, right? We can't get them back up to where they were quickly. It takes time. So not D. And then E, the answer is never fluid when you're having a heart issue, except for one time that I'll tell you later. Okay, but fluid, more fluid makes the heart have to work harder. And this is already a sick heart. We don't want to make it work harder. So the answers here are A, B, and C. Questions on that one before we go to the next one? Anything that brought up, anything you want to talk about there? Okay, let's go for question number 9. Try that one. Okay, let's do 10 more seconds. Okay, so the nurse is caring for a patient who's undergoing an exercise stress test. Prior to reaching their target heart rate, the patient develops chest pain. What is the nurse's most appropriate response? A, you are going to stop the test and monitor them to see if they're actually having a heart attack. Now, C, CPR. We don't do CPR until the heart stops. So if someone were to come to me and say, excuse me, I'm having some chest pain, would I throw them on the ground and jump and pound on their chest? Not quite yet. Not quite yet, right? So A is your answer for that one. Questions on that? Okay, let's try number 10. Try that one. Are these questions helping? Do you like these questions at the end? Okay. Okay, let's do 10 more seconds. Okay, so patient has an occluded coronary artery, so they're having a heart attack. They get an emergency PTCA, that's the one where they go in and do the balloon, and they're admitted to the cardiac critical care unit. So that's an ICU, a cardiac ICU. The complications that the nurse is going to monitor for include bleeding at the insertion site. That is the biggest risk, right? Bleeding is a huge risk of getting a heart cath done. Left ventricular hypertrophy, pulmonary edema, and peripheral edema, you would have to really damage the heart during that procedure to get any of those. Those are not likely symptoms of a heart catheterization. So bleeding is your big one there. Any questions here, thinking through that? Feel free, like I said, feel free to privately chat me if you're like, oh my gosh, I'm so stupid, I didn't know this, and I won't say your name. I'll judge you in my head. Feel free to let me know, okay? Okay, let's keep going then. Let's do question 11. This one is another select all that apply. Okay, let's do 10 more seconds. Okay, so this one is saying, what does a heart attack look like on an EKG? The answers are all of them except for A and B. Okay, all of those are possible heart attack like things. Okay, but A and B do not mean heart attack. How you feeling? I'll show you what all of these look like in week 5. So you'll know how to look at them, okay? Okay, ready for another one? Okay, this will be question 12. Try that one. Let's do 10 more seconds. Okay, so patients diagnosed with stable angina after going to the ER with crushing chest pain. He asked the nurse, did I have a heart attack? What are you going to tell him? You're going to say, no, you didn't have a heart attack. Stable angina is controlled with rest and nitro. So stable angina is not a type of heart attack. So that's why A and C aren't right. Now D, that's something I would totally say. You didn't have one, but you're gonna. But that's not the professional way to handle things, right? You're going to give them patient education related to coronary artery disease, related to stable angina, right? But the answer we're looking for here is B. Okay. Any questions on those ones? Okay, we'll keep going. Let's do question number 13. Try that one. Okay, let's do 10 more seconds. Okay, so you're providing discharge information for a patient who just had a heart attack. What are you going to talk about their modifiable lifestyle habits? B, they can change their high fat and carb intake to lower. They can increase their activity and they can stop smoking. A, obesity, modifiable, yes. Hyperlipidemia, possibly modifiable, but family history of heart disease isn't modifiable at all. So B is your answer there. And then D, stress levels, modifiable. Healthy BMI, we can get there. uncontrolled obstructive sleep apnea, yeah, but stress levels aren't, we don't want to say change your stress levels, right? Because whenever you say stop being stressed, just makes someone be more stressed, right? So we're going to say, instead of lowering your stress levels, we're going to say increase your coping skills. Okay. How you feeling? Doing good? Questions? Okay, got some more for you. Try that one. That one's a select all that apply.
Did you say
Wait,
this is
you
select
said,
all that apply?
yeah,
Only
I
select
can't select
it's
more
only
than
one. You
one.
do look one. Okay, just choose one then. We'll talk about it. Sorry, guys. Okay, let's do 5 more seconds. Almost every. Okay, you're done. Okay, so everybody chose a right answer because nobody chose antibiotics. All of the answers are right except antibiotics. So good job. You all got it right. Yay. Sorry about that. Questions on those ones?
No, just don't do that on the test. It'll really stress me out.
I will not do that on the test. I promise. Okay, let's see this one here. Okay, question 15. Try that one. That is just one. Just select one. Okay, let's do 10 more seconds. Okay, so this one, you're taking care of someone who got a PCI. Remember, that's where they go in an artery, do the balloon, do the stent. What's the major indicator of success? Meaning, how do we know it worked? Increase in the size of the artery's lumen. It opens the artery up again, is your answer. B, okay? A, increase in the patient's resting heart rate. Actually, their heart rate should go down when we fix a heart attack because their heart rate speeds up to try and get the clot out of the way. And then C, they should have an increase in arterial blood flow, not a decrease. Okay, that's time's up. Class is over. Anybody have any questions? If not, you're good to go.
Thank you.
You're welcome. See ya.
Thanks so much.
You're welcome.
So you know how I told you about my aunt and her heart attack
Uh-huh.
and whatnot? So I called her, and she's so funny because she can't tell me like half of the things that the doctor said to her, or even though she has the paper, like she just doesn't remember.
That's very normal.
But she says that she always has like this feeling like of pressure, like she lives in a small apartment. It's not that big, you know? So from like her living room to the bathroom, and then she comes back and she's like, or just simply talking. And I feel like out of breath and I feel pressure. Like, what is that normal because she just had a heart attack? Or does she have issues going on?
She might have issues. I would say have her talk to the doctor about it. It could be she's just tired and her heart was so damaged that it decreased her cardiac output and she's got to work up to being better again. But it could be that a massive heart attack causes heart failure.
Oh,
So I would definitely just let her.
Yeah, she had an appointment with the doctor, but she's literally like, she was cooking and cleaning, and I was like, can you just relax? Like, can't. She's like, but if I just sit down and watch TV, I just get so anxious. I'm like, okay, well, can you draw? Can you sew? Can you stitch? Can you, is there something else? And she's like,
yes.
She's like, no. When your mom does that, that just brings my anxiety up. That just makes me so nervous. I'm like, okay, well, something,
Then
you need
she
a
might
therapist.
need a benzo or a therapist, exactly.
Like, I think you just need a therapist because you just have a lot of things that you need to work through.
Yeah.
And then last night I found out that this he was like I knew him through church. He just went to Maui with his wife, and they were there in the morning, and then at night I don't know where they were, but he apparently had a heart attack and just died. And he was like completely like a healthy man. He's like a dentist, and like that was
Those are
just
the
the
scariest
beginning of
ones.
And is that because something was just blocked? Like his
Yep.
his
If
artery?
he died of a heart attack, it was a block in the coronary
She
artery.
wants to say hi.
Hello, Bree. How are you?
How are you? Well, she's over here trying to
Your
sneeze.
sister takes off after you and always wants to ask questions at the end, just like you, Bree.
Your sister, she takes after you, because wanting to ask questions after class.
I know. I told her you would say that.
Yeah, those are the scary ones. And it does happen like that sometimes. Like they don't realize they have cardio or coronary artery disease. Maybe they don't even have a ton of risk factors, but when it happens big and they go down really rapidly.
And there's nothing that she could have done at that point,
Not a
right?
thing.
Like no
Not a thing.
CPR, no.
I mean, you could have done CPR, but they need thrombolytics. He needs to be like actively been in a hospital when this happened to survive. Because even if she got his heart rate back, he probably would have been brain dead.
Wow. Yeah. So heart attacks are all around me this week.
Yes. Well, you're learning all about them now.
Well, those are my questions, but thank you.
You're so welcome, Carla.
See you later tonight.
See ya. Bethany, Eric, do you guys have any questions?
I just had a question. So I had a patient last week who had an ischemic stroke, and when they were performing the thrombectomy, her carotid artery ruptured. Is that a possible complication from other, like for when they're going through for the catheterization as well? Like,
it is possible, but it's not probable. That would be a very low chance of happening in the heart. The brain has more pressure and it's closer together. The heart, kind of the vessels go all over the place. So, and even happening in the brain, that's not super common.
Okay. Is that from like an increase in pressure as they're going through and trying to break it up?
Yep.
Gotcha.
It's all the pressure, because when you have a clot already and then you stick a straw in there, right, it's occluding more of the artery. They try and do it quickly, but
sometimes things happen. Okay, I was just curious because it's a similar process to get rid of
the patient die, or did they have to go to surgery?
They did an emergency intubation, and she survived, and she's doing all right, but she's older, and after that she wanted to be DNR/DNI because her like vocal cords are damaged, and it was very traumatic, and she's got like massive hematomas here. And then I guess they went in, I don't know if they went in both of the femoral, do they go the vein or artery?
To get to an embolectomy would be a vein.
She had hematomas on both sides from it, so I don't know if
they tried one and couldn't get in, and so they had to go to the other one.
Gotcha. Yeah, it was sad. So they're trying to figure out hospice or just what to do, because she's slowly going down.
She's not gonna live much longer. I'm surprised that she lived past the initial.
Yeah.
Jeez.
Well, they'd have to be careful with what medications too, since she had a rupture. So it can't be.
She had a rupture and a clot. They can't give her anticoagulants and they can't give her blood thinners.
Yeah.
So she's gonna die of a rupture or a clot.
That's unfortunate. Yeah. Okay, I was just curious because it's a similar process, so I was wondering if it has the same type of complication.
It does, but that's really rare. Like, I don't think I've ever seen that happen. Definitely not in a heart. I've never seen it happen. But the pressure buildup, yeah, it's possible. Just not probable. Yeah. Good question.
Thank you. Appreciate it.
You're welcome.
Have a good day.
You too. Eric,
Hey,
what questions you got for me?
I started thinking maybe you can't go back to check, and it's not a big deal. I've changed my study for this test
Okay.
coming up. I feel a lot better about it than I did the last time, but I was
Okay.
kind of curious of how I did the last time.
Let me take a look. Give me just a minute. It'll take just a minute to get there.
Okay.
Oh, you know what? This is being recorded. Let me just email you.
Okay.
I'll let you know. Okay.
All right.
Thank you.
And then I also had a question on the keto. How sustainable is that long haul?
I've been doing it for almost 2 years.
Okay.
It is sustainable for some people. Some people can't do it.
Okay. Well, you
But
look
I've been doing it for 2 years.
you look healthy, and so
Thank
I
you.
I need to do a change, and I'm wondering. And I went and bought a book, this book, a ketogenic diet book. I've started it, and I've gone down a little bit. I'm just wondering, can I do this for the long haul? Is it safe for the long haul?
It is safe as long as you're following it properly, right? If you just eat fats and you don't supplement with your protein in there, it's not going to be as easy. The biggest thing I've noticed that people struggle with is they think, well, this is low carb and this is low carb and this is low carb, so I'll eat it all, but then eventually, but that's too many carbs. You can only have a small amount of carbs, and that's the biggest thing. So since I've lost a lot of weight, a lot of people are like, well, how did you do it? And I say keto, and then they try and they fail. Keto diet, sometimes you get what's called the keto flu, like the first or second week, you start feeling like you have the flu because your body's kind of purging all the sugars and stuff, and it's transitioning from eating glucose to fat, but it's absolutely effective. It's absolutely sustainable. My friend was one of the ones that kind of turned me onto this. She has heart dysrhythmias, and she's thin, she's healthy, she exercises. The only thing that keeps her from getting heart dysrhythmias is a keto diet, and she's been doing it for 5 years. She says every time I eat carbs, like too many carbs, like more than 20 a day, she starts feeling her heart going to AFib.
Okay.
So it is doable.
All my life, I've heard about low fat, and fat's not a bad thing.
No, fat is not a bad thing. Fat helps keep you full.
Right.
So if you eat a higher fat and your body is eating fat, right? High fat is bad if your body's eating carbs, because then you're just building up fat. But if you take away the carbs, your body has to eat the fat. So a high fat diet isn't bad for you. In fact, my sister-in-law did keto because she has familial hyperlipidemia. She has really high cholesterol, no reason, just genetic. And she ate the high calorie diet or high fat diet, very low carb, and her her cholesterol came down because her body started eating the fat inside the vessels.
Wow, that's awesome.
Yeah, my blood pressure's come down. Like my blood pressure was low to begin with, but now my blood pressure is very low. So I have to take electrolytes to keep my blood pressure up. Like my blood pressure's come down. I've lost about 115 pounds.
Wow.
I feel better. I have more energy. I work in the basement, and my bedroom is 2 floors up.
Right.
And I used to have to like pause. So go to the basement, go to the main floor, pause, then go to, and now I can walk all the way up without wanting to pass out.
That's good. That's awesome. I need to do something. And
it is absolutely doable. And I think the first 6 weeks are the hardest because the first 6 weeks you're still craving sugar. But after 6 weeks, like I would taste a little bit of sugar here and there, and I'm like, oh my gosh, that is too sweet for me. That's disgusting. Like I am a huge sweets fan, and I thought it was too sweet because my body was no longer addicted to sugar.
Do you limit? Well, of course, there's a caloric range, but do you?
Not at the beginning. Don't limit your calories at the beginning.
Okay.
Limit your carbs at the beginning. And I'm saying at the beginning until you stop losing weight. Once you stop losing weight, then start addressing not only your carbs, but your calories. But I didn't start monitoring calories for like a year.
Wow, really?
Yeah.
And you just saw it coming down.
Just come down. Like the first week, I lost like 13 pounds in a week. And then every week after that, it's been between 1 to 5 pounds a week.
That's awesome.
And then I plateaued for a while. And then I started watching my calories. And then now it's going down slower, but it's still coming down.
Well, 2 years that's an awesome record. I mean, most
Now,
people.
obviously, there have been breaks. Like when I went to Disney
Yeah.
World, I ate carbs. I have
Yeah.
cheesecake every year on my anniversary. You know, I have bread for my birthday. But
You have to live. You have to live.
but it's only like one
life.
day. And I realized when I ate carbs, I would get massive headaches. My body's just not used to carbs anymore. So now, even like on Mother's Day, I'm like, I'm not gonna eat carbs. It's just gonna give me a headache. It's not worth it.
Right.
Yeah.
Well, one more thing, Dr. Sollis. So I made an appointment with you at 1:30, but I don't think I need to do that. If
Oh, it's the 1:30 appointment would be with the other instructor.
Oh, would it? Oh,
Uh-huh. Yeah.
Okay.
So just go in there and cancel it.
Okay. Sounds good. Hey, thanks, Dr. Sollis.
You're so welcome, Eric. I'll talk to you later.
Bye-bye.
Bye.